Thank you very, very much. And thank you, Fulani, for opening it up for us. My name is Durhan Wong Rieger, and I am really proud to be chair of Rare Disease International. I'm also the president and CEO of the Canadian Organization for Rare Disorders, and welcome everybody to our global meeting for 2020. It was not exactly what we had anticipated when we were planning this program, but I guess we're all doing things that we weren't anticipating at the time in which we were beginning to think about 2020. Certainly has been I think a remarkable year. For those of you who are with us yesterday for the AGM, you will have heard some of the highlights in terms of the opportunities that we've had from last year and moving forward into this year. And this is the opportunity for us to expand on many of the initiatives that you heard about yesterday, and also obviously to talk a bit more about where we're heading. So we have a very ambitious program for a fairly short period of time, but we're just really pleased because of the initiatives that have been taking place on the global stage, how much RDI and certainly all of our global partners have been able to be active in terms of moving rare diseases into the international arena, and also the many, many initiatives that are underway and are going to be taking place. In some respects, I'm a bit astonished, and I don't know how the rest of the council feels about it, that we've actually been able to make and to continue to make not only as much progress as we have, but to be able to look at the rest of the year and to really recognize we've got some significant opportunities for us for rare diseases. If you look at the agenda, we're going to start with a bit of an overview of what's happened with regard to how we got to universal health coverage. Have you again thinking about what the impact of having rare diseases in that UHC declaration will mean for us moving forward. We're going to have a wonderful example from Alba from Spain, who's going to tell us how they've actually been able to take advantage of that declaration and in terms of advancing rare diseases in Spain. We're going to then talk more about that global collaboration. Jan is going to join us, talk about the WHO. And we're going to hear from Matt Johnson, who's going to give us a really, really exciting, forward-looking, very ambitious collaboration with the WHO on a collaborative global network for rare diseases. Some of you may have heard about it already through some of our advocacy work. If not, I think this will be an amazing introduction to hopefully what will be one of the seminal activities that we will be launching this year towards a total difference in terms of how we can deal with rare diseases globally. And then we're going to talk a bit more about what we're doing in terms of coming up with what I think everybody has asked for, and it came up again yesterday when we did the polling. You know, do we have a definition for rare diseases? Can we come up with a common definitions of rare diseases? And this is becoming more critical as we work on the global stage. Do we all have a common definition that we can pull from? Not to say that every country will ever use exactly the same definition, but do we have a common platform? And that's important. And then again, another issue that has come up over and over again, and that is how do we get more drugs into the essential medicines list, and as important, diagnostics, and how do we make those more broadly available and truly trying to meet that imperative of leaving no one behind when it comes to actual access to medicines and diagnostics. And because we had significant requests, for those of you who can stay beyond the formal global meeting, we have included a session on COVID-19. Obviously, this is top of mind for everybody here. It's impacting every single one of our countries, every single one of our healthcare systems, all of our populations, and definitely impacting the work that we're doing as rare disease community, from the local level all the way up to the global level. So it's an opportunity for us to hear what's happening in different countries, but also more importantly to talk about how we will be working as a global community and what might need to be going next. So with that, I will now move into the first presentation, which is actually coming from me. I am really pleased to have the opportunity also to talk to you about universal health coverage, leveraging it to advance to a rare disease policy. Sorry, I have to finish this. So what is universal health coverage? We're all talking about it now, obviously, from the point of view of the WHO, which has been dealing with the universal health coverage for a number of decades now. It has some very important principles. Everybody receives quality health services that are needed without financial hardship, which is critical. It includes the promotion, prevention, rehabilitation, and palliative care and treatment, so not just care at the point of a disease. And it includes, importantly, access to essential, safe, affordable, effective, and quality medicines and vaccines. So that's kind of what the WHO has been working with in terms of universal health coverage. And then moving into more recently with the UN taking it up, but also part and parcel of what universal health coverage is, it's at a systems level, very important to understand. It means that the health systems have to be accountable, integrated, community-based, people-centered. It means that there has to be a competent health workforce. It means that there has to be adequate health infrastructure. And certainly, to supporting all of that, we have to have the right legislative and regulatory frameworks. And I think, as we all know, very importantly, that it means it has to be sufficient and sustainable funding. So it is not just getting the access, but it's addressing what has to happen at a system level at every single country. And importantly, and I think this has become much more for us as well, it is based on the principles. And these are just a few of the words that I pulled out to talk about it. It's equity. It's based on a principle of social justice, so that everybody, regardless of where they are in the world, but also in their own country, their own economic systems, and it's the elimination of discrimination and stigma based on many, many parameters, but also obviously rare diseases. Next slide, please. So here's an opportunity for you to take polls. Hopefully we've set up to be able to take a poll. Okay, so you've got an opportunity to say the status of universal health coverage and rare diseases in my country is: do you have good universal health coverage for common conditions and the same for rare diseases? Good for common conditions, but not the same for rare? Is it moderate for common conditions and still moderate for rare? Moderate for common conditions, but not the same for rare? Is it limited or poor for common conditions and same for rare diseases? Is it limited or poor universal health coverage for common conditions and it's even worse for rare diseases? Which one best describes the status for your country, or maybe you're not sure? And so if you can choose an answer and submit, that would be good. Let me actually just do it myself. Okay, I don't think Solani and I actually talked ahead of time how we actually get the results of that poll. So maybe we don't get them till the end. I'm not sure how we get the results to this poll. But I'll move on at the moment. Oh,
would
no,
you like
I got
to share?
Yeah, great. Thank you.
Right.
I was trying to figure out what do we agree on. Okay, so this is very interesting. So for the people here, a very small percentage, less than 20%, said it's about the same and it's good. About 40%, almost 2/5 of us, said it was pretty good for common conditions, but hey, it's a little worse for our rare diseases. And then we've got other people saying it's about moderate for both common and the same for the rare diseases. Again, almost 20% that's saying it's moderate for our common, but not the same. And then we've got some that says it's limited for common and same, and limited and poor, but even worse for the common conditions. I think if we look across this, we'll see is that a lot of people do believe that we've got good or at least moderate universal health coverage, but in every single situation where people are saying we actually, in each one of those good, moderate, or poor categories, it's actually worse in most cases for people living with rare diseases. So we all know we've got a lot of work to do. So as many of you will know, we actually had the United Nations Declaration on Universal Health Coverage last year. And for us, and certainly many, many thanks to Eurodis and Claire and on the NGO committee, everybody who worked toward it, the goal was to get rare diseases specifically mentioned in that Universal Health Declaration. So why, given that the WHO already had a commitment to universal health coverage, why was it felt important that the United Nations move into it? And really what was important was that it was much more than health. And it's what not only WHO recognized, all countries recognized, but the UN agreed to. That one, it had to become of the SDG 2030 goal so that we would have the aim of universal health coverage for all countries, all peoples by 2030. The goal was to halt the rising out-of-pocket health expenditures by providing greater financial risk protection. So we need to bring in other financial mechanisms. We had to bring in financial agencies, including the World Bank, to help bolster countries to ensure that they can actually get to universal health coverage, coming back to sufficient and sustainable funding. That UHC has to be fit to specific national needs while increasing the outlays for stronger health systems. So it's got to be customized. It's not one size fits all. It's not going to look the same in all countries, but in every single case, we come back to the health system, the health infrastructure, the workforce have all got to be strengthened. And it has to include all levels of policy making. Again, why the United Nations? The governments have to take a role. It cannot be left to the health systems. It cannot be left to the voluntary sector. It is, in fact, important that there's a multilateral system, and across countries, there has to be existing agreement. So this was very important. And the UN, then making that declaration, brings in many other agencies. It also commits, very importantly, countries to act. And it really commits, as part of what we were pushing for in many of the articles there, to serving at-risk underserved groups. And for us, this was key for us, that it would strengthen the efforts to address rare diseases and neglected tropical diseases. A huge victory for a very small line, but it means for us, hopefully, the opportunity to make sure rare diseases then is included, and that we move in every single one of those categories. As we're moving up in universal health coverage, we're also seeing the coverage and support for those with rare diseases at that same level. We all need to aspire to where a very few say there are right now, and that is we have good UHC for common conditions, and it's the same for rare diseases. And of course, it also included, which includes our people with rare diseases, increased access to health services for all persons with disabilities, truly leaving no one behind. Next slide, please. So how do we get there? And it was, I think, we get to one line in a United Nations Declaration, but obviously, and many of you were part of this odyssey with us to getting rare diseases in UHC, and just want to pay tribute to the tremendous amount of work that was done, both, very publicly, but also very much behind the scenes, both at, as we say, at a very top level, and certainly for all of you that participated at a bottom up level, and then bringing in many other line interests. So lots of discussions with UN officials, and I give full credit to people like Jan and Paloma and Clara, who really made an effort to go out to speak to the heads of state, the WHO officials, the state permanent missions. There were many, many meetings that took place, and also many of you as volunteers who came along on those, and also connected with your own governments to actually encourage the inclusion of rare diseases there. That part was extremely important, that we had the support from top down. Bottom up, obviously the patient advocacy organizations, the rare disease patient advocates, the Friends of UHC at many, many levels, including those within the UN. Bringing in what we call the aligned interest, the International Disabilities Alliance. That was huge support, and certainly very early on when we were part of that disabilities coalition has helped us tremendously, and hopefully also paying back into disabilities, Human Rights Council, and the work that we did in setting up the NGO committee on rare diseases, and being able to introduce rare diseases into the UN through that collaboration. And also then recognizing, again, when I say, sideways there, the mutual interest. You can't do it alone. You got to have friends. The Non-Communicable Disease Alliance, IFBMA, Médecins Sans Frontières, the LGBTQ or LGBTI collaboration coordination movement there, the Institute for Aging, a lot of meetings to have support from all of the other kinds of alliances that are part of the UN to help raise the importance of rare diseases as a specific designated entity there. Next slide, please. So on with that roadmap, we really did try to learn from others who traveled before us, and huge thanks also to all of these groups that when we reached out and say, hey, how did you do it? How did you get there? These are some of the groups that came forth that we became members of, that we worked with to understand what their path was, how did we get there? We created, and we really did involve many of you to leverage the opportunities, having the events. And some of you were there, were part of it, participating, supporting us in doing this. NGO Committee, International Universal Health Coverage Day at the United Nations, where we were the only patient organization that got to speak. The Rare Disease Day at the UN, that was an absolutely fabulous event. Again, for those of you who made that journey, who were part of us there, the first time we actually had a rare disease event inside the United Nations of that nature. And at the World Health Assembly again, the first time we actually had an official side event within the World Health Assembly, and also an unofficial event outside with one single goal, and that is to get that statement within the UN Universal Health Coverage Declaration when it was voted in September 2019. Next slide. So these are some of the key people that helped us, and I think I won't belabor it, but as you know, Helen Clark, who's the first UN person who actually stepped up and made that statement, and it's still a strong statement. You know, if we don't meet the needs of those with rare diseases, no country can claim we've got universal health care, and that's a big goal yet, because we know in many countries it's not the case. Dr. Tedros, who was so instrumental in giving us that strong support and who opened up for us the real hope that we were going to be able to be really very much included in universal health coverage. And of course, our very, very good friend, Rudiger Craig, who's continued to be a friend and is still working with us along the way. Next slide. Again, more very high level supports for us from Andrew Gilmore, who many of us will know has been instrumental in terms of speaking up on the rights of people with all kinds of stigma, but has been very good supporter for us. Access to quality health services, medicines, especially for people with rare diseases, from the ambassador of Thailand, who was the co-facilitator for the UHC very early on, pledging support for us. And of course, from the Deputy Permanent Minister of Japan to the UN, again, had some very good meetings with them. These were two key countries because of their leading role in universal health coverage. Next slide, please. And also empowering the patient community could not have happened if, you know, the people in the in different countries did not actually go and speak to their members. As we all know, the WHO as well as the UN is really driven by their member states, driven by their members. The rest of us can actually do the advocacy, but the actual people that can make it happen are those people that are the members. And we were really pleased that having a paper that we could share with you, a very hard, I think, research piece, but also then a much smaller piece that hope that many of you were able to take as part of our toolkit to go and talk to your countries. And we're truly grateful, every single one of these national alliances that you went to visit, who then came up and spoke on our behalf. That was a huge asset in terms of our being able to get that rare diseases into that statement. Next slide, please. And so this just gives you a little bit of a timeline of the map that we went through. It was a huge odyssey, and one that I think every step along the way, we felt that we were on the path and we were all very committed to it. But good gosh, I think none of us felt until that very last minute, well, probably not at the very last minute in September. I think we had some assurances. We saw the early drafts that it was going to be in there, but certainly not much before that. The recognition that, okay, this was a huge journey. And again, I'd like to really give credit to our policy folks, Jan and Claire Everest, who really, I think, continue to work tirelessly in terms of meeting people in the very, very long hours in which they put into making sure that that stays in place. And very recently, we'll have an opportunity to work even more collaboratively on that because Rare Diseases International has now been accepted as a member of UHC 2030. It gives us an opportunity to work with others toward that common goal, but hopefully also to make sure that the rare diseases are well recognized as everybody moves forward in terms of their implementation of UHC in their respective countries. Next. So here's another poll for you. Okay, inclusion of rare diseases in the UN Declaration on Universal Health Coverage helps me advocate more effectively for rare disease services and policy. What do you think? Does this help you? Strongly agree, neither agree nor disagree, strongly disagree. You don't have to know exactly how you're going to do it. We kind of want to know your emotional response to this. Is this going to help you? How do you feel?
Okay, Dion, I'm sharing the results.
Hey, okay. So almost 60%. So this is good. You know, I believe that I'm going to be able to use it strongly. Another third says agree. And a few of you are sitting on the fence, maybe because you're not real sure in terms of how you're going to work. And there are some of you who disagree or strongly disagree. And we do know that it's a big pull, and you know, even getting universal health coverage may in fact be important. And I will tell you quite frankly, it is just words. So it is the case. It's not going to help you at all if we don't have a toolkit for how to do it. It's not going to help you at all if you're not going to be able to, you know, actually advance and be active in it. So it is very true. It is not there just for the taking. It's not just there because it's there, and therefore you can expect that rare diseases, it is going to be included in universal health coverage in your country. It is in fact a long, hard pull, even for those of us who are very fortunate to be in countries where we have very good universal health coverage systems. Getting rare diseases in there, having it as part of the UN Declaration is really just a tiny little lever, but it hopefully is a pull for us. Next slide, please. Next slide. Okay, sorry. So this is just a few of the things that we said. I'm not going to belabor it. You'll have the slides later. You can take a look at it. You know, what are the ways in which you might use it? Part of a Bill of Rights, using multiple media methods, aligning with rights-based groups in your own country, in your own environment, inviting local and regional WHO representatives to your events, and they are in fact available, including other populations in rare disease actions. And that for me has been a huge part. Who else is affected? Who else, you know, is in that situation, whether it's under disabilities or people that are struggling with access to basic care? Can we expand the movement? And we're getting more people that are asking us, I know, as rare diseases, how can we be part of what you're doing? Because we think you'll give us a leg up. So that's important. Next. So rare disease. So this is our commitment in terms of UHC 2030. It is a both two-way street there. It's a commitment for us to be part of a global movement to help build stronger health systems for universal health coverage. It is also an opportunity for us to make sure that in each one of these key asks that you see here, that rare diseases has a part. But it does mean that we have to show up. We have to be there as part of it. So it's the opportunity, but it also means that we have to also do the hard work, make the commitment. Somebody sent in through the chat, and I thought it was very important. Yeah, let's not forget the schools. The schools are a huge place in which we can, you know, take advantage of having rare diseases become equally addressed. It's not just health, it's schools, somewhat in the workplace as well. Thanks very much for that comment. The next slide. So these are some of the other things that are happening in terms of the UN. The UN actually made a comment, and I just included this because we're going to have the COVID discussion later on. The UN had actually presaged certainly COVID-19, but also because there have been so many pandemics, epidemics before, and they say there are going to be complex emergencies that will likely hinder UHC. It will throw us off course, or it will try to throw us off course. And in the declaration as well, there is the need for coherent and inclusive approaches to safeguard UHC in emergency. So we do not give up on UHC, even though we're in the face of an emergency, and we need to ensure the continuum and provision of essential health services and public health functions. So again, we're all really, caught up in COVID, and we need to be, but we cannot abandon what the needs of people with other conditions and the need for continuing to move forward on universal health coverage. The UHC 2030 recent statement said, faced by the COVID-19 crisis, it is crucial that world leaders remember their universal health coverage commitments. And we do know that this is in fact the bigger umbrella, but also we cannot give up on the progress that universal health coverage helps us is making in terms of dealing with all kinds of health conditions. And the WHO coronavirus guidance, just putting in there again, maintaining essential health service. And this is what we're all dealing, right? We've got the balance, we've got demands of responding directly to COVID-19, but we also have to make sure that our health service delivery, the risk system does not collapse. It's always a balance. I know all of us are hearing a lot about the concerns about the balance between economics and opening up the workplace and safe and healthy, but also within health. We need to be concerned about the balance. And this is not being selfish. It is taking that big picture, which universal health coverage helps us to do. Next slide, please. And this is your last poll. I would be interested in having tools and training on how to leverage UHC to advocate for rare diseases. And this is really to us as RDI. What do you think? Do you want to need to have this? Would that be something that you would take part in? Some of you have heard our work plans when at the AGM, and we are moving forward to looking at what we need to do. Okay, oh, well, that's good. Okay, 70% strongly agree, 25% said I would agree, and only a very few of you says I'm not real sure. So I think this does give us some real strength in terms and the motivation to move forward in terms of how are we going to do that. And definitely it's part of our work plan for RDI for the year. That's it. Thank you very, very much. I don't think we're going to do questions right now, are we? I'm sorry, I'm not really sure.
Now let's keep the questions for the end of the session.
Okay.
So Alba, can you share your presentation with us, or would you like me to do it? Alba? Oh, there you are. Okay.
No, I think I can do it.
Okay, yes. Great. So let's leave questions for Duran and Alba at the end of the session around 2:45.
Okay. I have so many windows open that I
can't. I know. I have that problem sometimes, yeah. But tell me if not, I can take over.
No, it's okay.
Okay.
Okay. Through my presentation, hi to everyone. Good morning, evening, afternoon, night, or wherever, where you are. I'm going to try to answer to Durhan's questions about how a global policy action can increase RDI members' leverage. I'm going to try to do it by presenting how we advocate in Spain for the integration of rare diseases in national policies with the framework of the universal health coverage. I must start by saying that it was not an easy task, not just a question of one day or one meeting action. It was the result of several agents working together in a very planned strategy that took almost 3 years to get results. At the beginning, we didn't even know what will be the outcomes. We just believe in a global policy and to try to include rare diseases in the UN and WHO agenda. From the first beginning, we got benefits by involving our authorities at national, regional, national, international, and global level to this global policy. And it allows us to approach our policymakers to rare diseases. We did it holding on common tools as Rare Disease Day, conferences, and we try to involve in very different actions, WHO side event, UN event, and above all, the electoral process. And to end with, I will show you how important is at a national level to work with a global strategy, also to fight against local barriers and all those difficulties countries as Spain we face with that decentralized system. So let's start with the beginning. And we participated long time ago, in November 2017, in an RDI and I wrote this webinar about how to put rare diseases on the United Kingdom, United Nations agenda. And we just were interested, so we received a template to send a letter of involvement to our permanent mission representative in UN and our Spanish permanent mission representative in Geneva. And it was very easy. We just have to adjust to our language and include our logo in the letter. And we had a very nice welcome. They were immediately interested in us, and they did it because we were by the hand of an international movement. First question was how many regions and how many countries we represent by the rare diseases community. And they just give us some recommendations because the agenda was very easy. We just asked how to include rare diseases in the UN agenda. We got 2 meetings, one meeting in Spain with the UN department in Spain. It was in a Spanish meeting, and we also were received in Geneva by our Spanish permanent mission representative in the WHO. This first attempt led the politicians to push us to try to include the rare diseases in the high-level meeting on NCDs. That was not finally successful, but at least they were engaged with rare diseases and they were concerned about our needs. And we also got the involvement of our Minister of International Affairs and our Secretary of Health in Spain to push rare diseases to be in the WHO Assembly. It's interesting to highlight that his declarations were to support further through the international patients movement, not just further, just do it next to RDI and other patient organizations and alliances worldwide. We also got their commitment to try to support us to have a official side event in the WHO Assembly, but it was too late. So at least this commitment got to us a high impact and an involvement for future events. These first attempts also allowed us, by the hand of Father Pov in Argentina and Oliver in South America, to be mentioned. Rare diseases were mentioned at the non-communicable diseases high-level meeting in September 2018. So they had a statement declaring their involvement also with rare diseases. And then finally, we got a real involvement of our authorities in the UN event organized by RDI and NGO committee in February 2019. after a couple of rejections, we finally got their accept and their endorsed to be part of this UN event, and they were one of the 15 countries that sponsored the UN event. That was very meaningful to us because we achieved the decision maker in charge of national strategy of rare disease in Spain was presentially way there in the UN event. They made some declaration, not very satisfying, but at least it was a base to hold on our national strategy to get that involvement with the universal health coverage. We also were there through the video of the Rare Disease Day because one Spanish testimony was in the video, and so also as it was displayed along the ceremony, it was a way to participate of this UN event, and for sure further joint event, and we were there. But this UN meeting sponsoring was not the only achievement we get. Also, by supporting a meeting between our Spanish permanent mission representative in UN and Durgen, Jan, Claudia, and Clara, we encourage a reception from our Spanish ambassador the day before of the UN event. And that was apart from a point to have a meeting and to network with other alliances and other participants in the UN event. It was a chance to have a face-to-face meeting with our decision maker representative, but also to get a strong commitment from Spain, because if the ambassador was receiving rare diseases patient organization representative in his house, that means Spain is really engaged with rare diseases and the national strategy. Next step was the Rare Disease Day in 2019. Rare Disease Day, we based on the Sustainable Development Goals, our position paper, and that was very useful to us, not only to raise awareness on the Rare Disease Day and rare diseases, but also to work on what will be the future conference, what we call Global Challenge and Holistic Challenge Conference. It was a good practices change at international level. Many of you today were represented there. We had the chance to have there Peru, Uruguay, Luxembourg, also AFM Teleton, Frambu, for sure Paloma, presenting the importance of the universal health coverage. All of them showed to our queen and to our policy makers different landscape, different initiatives, and different level of achievements in terms of rare diseases policies. And that was very good to give a whole view of what's going on all over the globe, and to get a commitment from our governments, not only at national, but also at international level. And finally become the electoral process. In fact, we had 3 electoral processes along the last 2 years, also at national and regional level. And we base our electoral process strategy on the words our president, Pedro Sanchez, said at Universal Health in New York, September 2019. His words severed that the basis of our national strategy of health was the universal health coverage, and that was the way we commit them. And then we present to every political party our recommendations to include in their electoral programs rare diseases based on the Sustainable the development goals and also universal health coverage. Sustainable developmental goals was also very, very useful to us to raise funds, because our public funds and call projects at governmental and public level are very committed with sustainable goals. It's a commitment with rare diseases. They included in their roadmap rare diseases inside of the universal health coverage strategy. And that was one of our main achievements and our main goals through all this strategy. But I cannot forget about the cohesion that international policies and international movement gets inside of Spain. Because since the beginning, European recommendations help us to promote national policies on rare diseases. As many of you know, Spain system is a decentralized system. We have 17 health systems, 17 regions, and that's not very convenient for rare diseases and for healthcare. But when they speak in terms of ERN or in terms of international collaboration, they are ready to work together. So this is very encouraging and very useful to us, because they think in terms of international, not in terms of region or in terms of nation. In a resume, this international action and global strategy support us to get policies at regional, national, and also international level. Also positions FEDER and patient organization in a much stronger situation, because we are not just a national patient organization, we are an international patient organization, and also gives us many chances basing our advocacy strategy on the international strategy. I want to encourage you to take the chance. Now RDI is working on that universal health coverage toolkit. I want you to tell you, please give it a try. And if I can be useful or supportive by my experience, please contact me. I will always at your disposal. And thanks very much for your attention. Any question, please go on.
Thank you so very much, Alba. That was amazing content, but also an amazing presentation. And certainly we recognize by the kind of commitment and the emotion that you put into it, that this is something that you carry forth, certainly not as a piece of work, but as a passion. So thank you so very much. And I can tell you honestly, Alba means it when she says, if you need any help, reach out to her. She is really there ready to help. I know that last year, she came to the Asia Pacific Alliance of Rare Disease Organizations, came in to help share her experience. And I know I speak on behalf of Rito as well. It was a huge asset to have Alba there to share what, they've been able to do, not only in Spain, but in Alibert as well. So we know that you mean it when you say you're there to help and always are open to the support, but also, as you say, taking from others. Okay, are there any questions that anybody has? One of the questions is, will we be making the slides available? I presume that's yes. That the slides will be.
Yes, the slides will be available. So will the presentation on our website in the next couple of days.
Excellent. Okay. Anything else? Okay, there's a raised hand here from Yasser. Can we have, I suppose, Is there a way to unmute the screen, or can you put in your question here? Now, Alba, I know that you started way before the UN Declaration, and you were very much a part and parcel of it. Was there, has there been any opportunity for you now that it's actually been in the UN Declaration to think about any further usage that you can have in terms of that as part of universal health coverage? Are there any plans that you've got within FEDER, or maybe even with Ali Bear? I know you've got a tremendous role in Ali Bear. Are there plans or opportunities that you can see how we might better leverage the rare diseases there
right
now?
We are, I think as everyone with the COVID crisis, we are a little stuck, and we are just waiting some time to start again with our advocacy action. But I'm sure also RDI will give us new chances with the toolkit, and we could start again and reinforce our previous action.
Well, I really echo what you're saying. I think we're all feeling a little positive. I'm hoping that, we're going to kick off the session later on today with the COVID-19. But I think that the UN, premonition that, we'll have emergencies. This will not be the last possible, epidemic or something else that could possibly derail UHC and especially rare diseases. So I think for us, as you're saying, it's a huge question of how do we actually continue forward, with rare diseases, with UHC, even in the face of these epidemics, or there's some better opportunities. So we'll be opening up that discussion. Hear what you're saying very much, though. There's a question here. To you, Alba, from Victoria Headley. She says, if you were to do this again, what single thing would you do differently, if anything? And by the way, it's great work as always, she says.
Wow, it's an interesting and challenging question. Just let me think about it for a second. I will have a clearer roadmap, because at the beginning, we really didn't know what we were aiming. We just wanted to include rare diseases in the UN agenda. Now we know that the good way is universal health coverage, but at the beginning we had a couple of non-successful attempts, as for example the non-communicable diseases, and that made us to lose some time, because we were like a little lost, and we didn't put all the efforts on the mainstream. And I think right now we have a clearer roadmap, so we can work better on that. And maybe we should have planned better our action, not to be so just give it to try. That right now I think it's going to be easier, but maybe was one of the things I would have done different. Yeah.
Okay, so rather than being just opportunistic and as things come up, try to be a bit more strategic. But hey, you know what? That's always easier to think about after the fact, right? I'm not so sure. Okay, let me try again with Yasser. Yasser, can you? I see you're unmuted. Can you speak or ask your question?
Do you hear me?
Now we hear you. Yes, please.
Thank you. This is Karina from Rare Diseases Foundation of Iran. Unfortunately, my ID was not working, and I'm talking on behalf of RDI RT. Hello to everyone. Congratulations on your achievements. And the question is that we are very happy that rare diseases are going to be included in UHC, and there's going to be new plans and policies in this regard, and we hope that there will be some considerations regarding especially our country. We have sent messages to you all, and of course we have participated in the declaration, and we hand it to our MOH and the representative mission in New York, that we all agree to UHC. And we hope that it will work, especially in Iran, with no support. And we expect you all, our dearest colleagues, to help us with the issue, to see how we can bypass the sanctions to get more support accordingly. Thank you. I'm not going to take your time too much, and I congratulate Alba because I visited her in Madrid for the session we had on our first atlas for rare diseases in Iran. And I hope that we can participate in your collaborations furthermore, more than before. Thank you all.
Thank you so very much for your comments. We know that, you know, in many cases, it's so much more difficult with everything else that's happening, but we've all I think, are committed to, you know, rare diseases, and certainly health and rare diseases, including, you know, it should not be subject to the politics, and definitely know that we're proud to have Iran as part of RDI, and we're really committed to working as much with you as possible, and definitely appreciate your sharing the updates that you've got. We're going to run tight on time. We ran a little bit late, so I'm a little bit concerned about opening up the mic. So we do have a couple of questions that I might kind of get to kind of quickly. I know that you know, we have a number of concerns here. I think Tony had a very interesting comment that I wanted to bring back. He says he's concerned that, Tony Holland, that UHC is defined too narrowly. And for many people with rare disorders, the solution may or may not be medication, but rather good quality care, the availability of reliable information, access to skilled surgery, et cetera, et cetera. How do we advocate for these? And those are hugely important. And I think, as you saw with the WHO definition of UHC, but even more so under the UN, that UHC includes so much more than medication, includes so much more than just healthcare, but really is embedded in good quality care, as you say, but also all the other aspects, including communications, information, etc. So I think it's a good reminder to all of us that when we're advocating for UHC, and certainly for the inclusion of rare diseases, yes, we can get fairly narrow caught up in terms of diagnosis or treatment or access to specialists, but really all the other components of it are hugely important, including mental health, including the issues of stigma. So it is built in. It's really clearly outlined in both the WHO and the UN declaration, but so it's up to us to pull on those. But it really, and I think we've seen in many countries where some very comprehensive programs. I point to Taiwan, where their program is really based on a lot of components, including support for social services, including access to quality schools, education, etc., as education and as part of it. So I think this is indeed, you know, really an important component of it. Okay, Toon, I'm going to see if I can squeeze you in for one question, if you can do it quickly.
Can you hear me?
We can hear you.
Great. Thanks for all the great presentations and efforts and including obviously rare diseases into this resolution. I had a follow-up question to Alba, especially kind of what it means locally. Can you extend a little bit kind of what you have seen as the extra opportunity with this universal health coverage resolution on top of what we've seen in Europe already over a number of years in terms of efforts of countries adopting national rare disease plans? What has been a different element for you that you could have leveraged as part of your efforts?
Okay, our president was in the high-level meeting on universal health coverage. It's very common that our politicians, our authorities go to this kind of meetings, it's international meetings, and they show their support. And we use that declaration to base our strategy. And it was true that it wasn't the very first time we mentioned the universal coverage. We had been mentioned universal health coverage and rare diseases at UN agenda since 2 years ago. So it was not new for them, but it is true that we take the chance, we take advantage of their polite implication in universal health coverage to say, so if you are involved with universal health coverage now, we want you to give us a feedback. I want you to know how are you going to include rare diseases and how you are going to leave no one behind. Also, we complement with the action made before because some of our Ministry of Health departments were involved in the UN event. So if they were in the UN event and in supporting rare diseases, and they also support universal health coverage, it must be linked. And now we can ask for real and concrete actions. It's true that we are still waiting for that, but we can right now build a much stronger advocacy strategy, because they must be loyal to their own words and to be consistent with their commitments in the past. I'm not sure I answered to your question.
Thank you very much, Alba. I think you speak to the ability to hold accountable. And actually, you know, as you say, it's not just words, it's not just a commitment, but what are the actual actions? And it gives us a lot more opportunity to actually come back and say, what have you achieved? What have you done? Because the commitment is there. Okay, I'm going to move on because we are going to. I want to try to see if we can keep on time. So we are just up to the point in the program where we actually are going to be moving forward in terms of building on our global collaborations. And certainly a huge part of that was our recent signing of a memorandum of understanding between RDI and the World Health Organization. So I'm going to turn it over to Jan LeCamp, who's going to talk to us about this as another major achievement of this past year. Yeah.
Hello.
Jan, are you doing the slides or somebody else?
Absolutely. They are just coming here. I'm just checking if it works. Do you see them?
We see you.
Super. You see me? That's not what I want. I want you to see the slides.
We see the slides.
Okay. And now you see Duran by Tedros. Okay. So good morning, good afternoon, everyone. Apologies, I will repeat some information that some of you already know because you've been with us along the last years. But for the one who are more new, we need to put things into perspective, a perspective both of time frame, but also a framework of work. So first, the relationship between WHO and RDI, we need to go back to the fact that up to 2018, WHO had not taken any action or ever mentioned rare diseases. So that was the first advocacy success, to have a statement from WHO Director General on Rare Disease Day. And we had a meeting right after that as RDI with Duran and Paloma and with some directors of WHO around the new Director General, where clearly there was an opening of collaboration, recognition of the issue. And already we were working with WHO in office in New York, Natam and Abbey, and with different permanent missions, as you know, and that's what Duran just reported. And rare disease were included in the Universal Health Coverage Political Declaration in September 2009. So, and then we signed the MOU, the Memorandum of Understanding between RDI and WHO in December 2019. So we had already had exchanges and groundwork, I would say, for 2 years to get there. But when you look at it, it's only 18 months to be to that point. So we were pretty happy with these developments. So what we will develop now in a moment is what are the long-term goal of this collaboration with WHO, but what is in for 2020. And these are the two elements which will be in, and I will detail that in a moment. In addition, there is activities which are not in the immediate objective of the collaboration on which we are working in parallel, like the international classification of rare diseases and having a dialogue with the scientific department of WHO on codification and making the link also to human phenotype ontology and things like that, so that progressively there is an understanding that we need all these normative approach around rare diseases, which are essential to increase the knowledge from the national healthcare system after that. But also starting the work on essential diagnostic tools and essential medicines, and that is on our agenda today. The MOU Article 1 indicates the long-term objectives. So for you to know, we have a document with WHO, which has no status, it's just a document between us of discussions, which is covering the decade, the next 10 years. And then we have in the MOU objectives which are within the WHO general program from 2019 to 2023. So we're trying to show to WHO how rare diseases and RDI in particular can contribute to help WHO reach their goals. And in that way, they are helping us. And so that's why the framework is within the global program, the general program of work of WHO. And the specific objective over the 5 years for RDI and WHO is to increase awareness of rare disease and their visibility in the healthcare system. So awareness are things like Rare Disease Day and other activities of this type, or campaigns, information campaign. Visibility is very much codification, classification, etc. So all the normative aspects to increase the visibility in the healthcare system. The second objective is to strengthen the healthcare systems, including improving access to accurate diagnosis, prevention of comorbidity, and promotion of multidisciplinary holistic care. So I hope you're happy. It's words, they're only words, but I'm pretty happy that we have as an objective over the 5 years, immediately that kind of language, multidisciplinary, holistic, focus on diagnostic prevention of comorbidity. The third objective is improve access to affordable and quality treatment and care. And we know that's a big challenge. And objective 4 is to encourage member states to adopt strategies to address rare disease challenges at national level within an international policy framework. And obviously, that's not going to be the first thing that WHO is going to do. First, we need to put in place a certain number of milestones before we can get there to have WHO starting to engage member states, or at least letting us engage member states on their behalf. Next slide are the specific objectives. So as I mentioned at the beginning, for this year in 2020, we have 2 specific objectives. The first one is within the work of universal health coverage and healthcare system strengthening through the global networking of specialized expertise. And the language, the text which is in the Memorandum of Understanding says that WHO and RDI will collaborate to improve the diagnostic of healthcare, so the general objective that I mentioned before, with specifically a global network of multidiscipline specialized expert centers for rare diseases through a structured approach, grouping rare diseases by therapeutic area, so to be inclusive of all rare diseases, to leave no one behind. So you see the connection with what Joanne was just saying on SDGs and universal health coverage, leaving no one behind, etc. So we have that kind of approach there. And specifically for this year and next year, RDI will prepare for WHO a need assessment study, so to propose the conceptual and methodological framework to create such a network with a strategy which is both bottom-up approach that promotes the identification and support of highly specialized multidisciplinary centers of expertise, and to connect the centers of expertise regionally and internationally into future WHO collaborative global networks for rare diseases. So that's what Matt Johnson will present more in a moment. The second objective that we have in this MOU is to work on the objective of data sharing to improve the recognition, we could say visibility, of rare diseases in the health systems. And to start with is to have an operational description of rare diseases and key figures about the prevalence or incidence of rare diseases. So that's what we will discuss also in a moment with Anahat. So we're starting now, going from 2 years ago, 18 months ago, to just having a declaration from WHO, then engaging into legislation, the first legislation with soft legislation, but with UHC. Now the memorandum of understanding, so framework of work, and now we're starting the operational work. So now the vision, before giving the floor to Matt, the vision of this WHO collaborative network. Sorry, I need to move the window. The WHO Collaborative Global Network for Rare Diseases, and I hope you appreciate that they are called like that. It's not me calling them like that. It's not Matt or Duran calling them like that. It's how WHO wanted to call them into the MOU with RDI, to call them WHO Collaborative Global Network for Rare Diseases. And the goal is to connect the major academic, healthcare and research organizations. So basically major hospital with research capacities and linked to a medical university. And where there exists already expertise on some rare diseases, multidisciplinary expertise, which maybe is not well structured to take care of people with rare diseases, but could be. So there is this expertise, these specialist capacities, which can be multidisciplinary within these healthcare research and academic centers, and to connect them at the regional level and at the global level. In that way, the initiative contributes from the perspective of WHO, but also for us, by the way we're approaching it, to implement the universal health coverage. It's one of the ways to provide access to diagnostic, to provide access to prevention of comorbidity and to the initial holistic care. And to strengthen healthcare systems. Why? Because the healthcare systems are able to respond better to the needs of their populations, in particular, the vulnerable populations affected with rare disease, diagnosed, misdiagnosed, or undiagnosed. Within the SDG Agenda 2030, the ambition of this global network is potentially to serve 2 billion people in the world. Okay, that's quite ambitious. What does it mean? It means that we're looking at the objective 2030 of SDGs and we say, okay, 10 years from now, how much people could benefit from that network? And our approach is to say we're going to look at the countries where there is already existing well-advanced facilities. There is the countries where it's less advanced, but where there is major cities which have the capacity with the big hospitals and medical university and research centers. And by connecting them, we could already provide a better access for 85 million people with rare disease in the world, which if you take the prevalence of our diseases means a wider population of 2 billion people. So it's not the world, but it's getting to the world progressively. And specifically, the goal of the network is to expedite and provide accurate diagnosis. So the angle of that strategy is diagnosis. Raise awareness, raise visibility in the healthcare system, diagnose more patients, and try not to misdiagnose and try to diagnose quickly. So reducing the time to diagnose, reducing the misdiagnose, and addressing the diagnostic odyssey so that it takes less than 1 year by 2030 to be between the time of the first contact with the doctor and the diagnostic. Second objective is to break down the traditional barriers in accessing care, often experienced by patients and their families through open, direct self-referral. And here you will see the link with some of our work with the Global Commission, right? Trying to not to wait that the healthcare system are reinforced and stronger, but that we can empower themselves, the patients and the primary care providers, to help refer the patients to the experts, so potentially to these hospital centers, to these hubs. And overall, all that with the ambition of providing holistic, affordable, quality, highly specialized healthcare, which obviously is an ambition, but the approach is from the beginning to try to aim for quality outcomes, for measurable health outcome for patients. And now I stop and give the floor to the video from Odiger Crash, who is the director of Universal Health Coverage at WHO and healthcare system. Davor will launch it.
Dear colleagues of the RDI community, I'm really sad that I cannot be with you today in person to validate trends in the future of rare disease and health policy. As you are designing potential future scenarios based on these trends, I'm humbly adding some thoughts. I was particularly pleased to see the analysis of the emerging trends that you have conducted. This gives a strong basis to build potential scenarios. I would complement such trends with those that will have an impact on the diagnosis and treatment of rare diseases. When it comes to new technologies, I would widen the view slightly to include innovation, for instance, in communications technologies, as these might have an impact on potential innovative networks and centers of excellence globally. You have shaped this foresight study very well. You have asked us to look 10 years ahead. What would we call a great step forward? Where do we want to be? Well, for my part, I would like to see a network of centers of excellence of rare diseases globally. These centers would cluster groups of rare diseases and bring together world-class experts in the diagnosis. They would be connected virtually with care centers around the world and stand by for acute advice during patient crisis, and be virtually present at the bedside. These experts would be partners of treating health personnel and counsel when it comes to the organization of care at home. Such centers would be top-notch research places when it comes to innovation in diagnostics and exploit ever shorter innovation cycles for diagnostics and treatments of rare diseases. They would be world-renowned training centers and offer twinning opportunities. They would be financed through international agreements of healthcare purchases. The health impact of these centers of excellence will be to reduce the time it takes to diagnose a rare disease, to improve the patient-centered care, and in the best of all scenarios, they would also decrease the number of patients with rare diseases, as some more might be found to be curable. Dear colleagues, in WHO, we have a clear compass that orientates us conceptually and in prioritizing our work. It is the global program of work in which we seek to reach 1 billion more people that will benefit from universal health coverage, 1 billion more people being safe from emergencies, and 1 billion more people enjoying healthier lives. We are committed to leaving no one behind, and this includes obviously also people with rare diseases. This current GPW runs until 2023. It is guided by the Sustainable Development Goals and is an operationalization of these goals in a 5-year period. I'm sure that the scenarios and options that you are developing will be operational as well. To this end, you are looking at the PASL categories. Each of the categories is obviously important to consider in developing strategies that drive the implementation of the scenario you developed. For instance, the availability of certain medicines should not be a matter of charity, depending on the goodwill of a donor who could, if the wind changes, withdraw the commitment. Medicines for rare diseases have to be part of a transparent pricing system and included in prepayment mechanisms of health insurance. As we all know, this will require serious efforts by all partners, as the current practice is indeed intransparent and confidential. WHO has initiated a fair pricing dialogue with industry and partners, and thus makes the economic argument to provide needed medicines for everyone. But there is also scope in looking at the interdependency within these categories. Only if we can show the way to such transparent pricing of medicines will the political argument of leaving no one behind become a realistic goal. Only if we link the societal and cultural shift towards universal health coverage with an ethical dimension that no one should die because of an inability to pay out of pocket for hugely expensive drugs, can we also make the case for rare diseases. I wish you fruitful deliberations, and I'm grateful that you consider WHO to be on your side.
Thank you. So that gives you a message from WHO on this aspect. With that, I would like to turn to Matt Johnson. Matt Johnson is new to you, to this audience, but not new to the topic. Matt is RDI, the new RDI Healthcare and Collaborative Global Network for Rare Diseases advisor. So he's working a certain number of days for us, I would say, during the year. But he brings with him a long experience in Europe on the European Reference Networks, and before that, into the public service of the National Health Service of the United Kingdom, where he developed the specialized services for rare diseases, commissioning services. So Matt, the floor is yours.
Thanks, Jan. So I've prepared some slides which just to expand really on Jan's vision, the vision in the Memorandum of Understanding. When we think about a global network for rare diseases, we're thinking very much in the WHO terms, i.e. by 6 regions, and trying to think about how we connect those 6 regions, understand the needs of the 6 regions as well, because services in different countries in different parts of the world can be very different in their structures. We have some guiding principles that it's 1 global network, not 24 like we have in Europe. We have 1 global network for rare diseases, which connect global hubs together. And that these hubs really are lighthouses for rare diseases, recognized in their own countries as leaders for healthcare, education, training, and research. But for one of those hubs to be recognized and join, we need them to be assessed against some standards which we're going to develop, but also be endorsed by their member state. And when we have those hubs active at a global level, we think that we want to structure those activities under global programs of care, which are time limited, which maintains good participation because people elect to take part in something, maybe research or clinical guideline development for a specific cluster of rare diseases. But when we think about a hub, the role of a hub has 2 functions. There's one level where locally they should be there to improve access and coordination to high quality care and treatment and diagnosis, very much supporting the development of that health system's competency in rare diseases. And that's why we think the national endorsement is very important to strengthen the local health system's competencies in rare diseases. But when they come together and collaborate globally, we think that the first and foremost thing for these hubs to do is to improve access to quality care and treatment, i.e. the implementation of the universal health coverage, and removing those barriers locally for people, vulnerable and isolated populations to come together. And obviously we think that education and training is an important thing for them to do as well. Also clinical guideline development, exchange of knowledge, data, and conduct research, but those are more secondary. We think that the 3 components really of these hubs should be that they should collaborate, that they should show how they use technology as an enabler to share knowledge and expertise and share their experiences and build the whole global network's competencies and capacities, but also to coordinate with multi-system rare diseases. Whilst we have fantastic experts in specialty areas, it's around the collaboration and coordination of those experts. So we think it's key that the hubs provide virtual healthcare and specialist advice, and they have a platform to enable timely diagnosis and to share data as well. But to build local continuity of care. With COVID, we know that now health systems need to be a lot more lighter on their feet and agile. So we think that their role in developing the competencies of rare diseases in their health system is key too. So the components we have come up with so far are, we believe that not only are these global hubs or in countries which don't have a fully fledged or singing or dancing rare disease centre, but could specialise in one or two rare diseases, we think that probably should be an affiliated member function. But we think also that patient organisations are critical and should also be formal members. And as I said, that those two elements come together, forming the global network under the 6 regions. When we think about a hub, we think about 4 key domain areas: national coverage and rare disease coverage in terms of expertise. Anna's talking later on, and we all now know the 98% of the population are affected by less than 400 rare diseases. So we think that, you know, one of these lighthouses probably covers the majority of those 400 conditions in their specialties in their hospital. But we need to ensure that they have good coordination and collaboration with other centres for those 1 in a million prevalence rare diseases, because they could be elsewhere in another part of the country or in a neighbouring country. So signposting collaboration is key to know and see. Resilience, systems resilience, I've mentioned already, and how they use technology as a way to move forward and enable good collaboration, coordination of care. We think that the recognition of the hubs in their own countries is important, because that strengthens the footprint of the global network. Because we build the local health systems competency, we are ensuring good coverage then of centres, geographical scope, and therefore we're improving people's access to universal health coverage. One of the feedbacks so far from RDI members was, whilst national endorsement is really important, when we say national endorsement, we think it should be threefold at the moment. Not just the national authority, Ministry of Health, but it should be done jointly with the National Patient Organisation, the National Alliance, the Ministry of Health, and the leading research body as well. So the national endorsement is key politically to recognise that expert centre as a global hub to come forward, but under a rare disease plan, because we think that that should be in that context. And globally, members of the network, as I said, patient organisations and those affiliated members for countries which don't have the full range of expertise because of population sizes. But a hub, should it be a single hub or should it be multi-centre? We think it probably could be either. We want it to have the flexibility in the scope of this, so we could have a virtual hub of 3 or 4 hospitals, maybe in Canada, coming together as one global hub for Canada, as an example. I've talked here already about the primary aims. I won't review that again. But these programs of care, I think, is an interesting concept. We think they should be thematic in their grouping. There should be a clear action plan, time limited, but we want to create an interface with third sector partners. So therefore resources, whether it's with pharmaceutical organizations or whether it's with Microsoft or IT organizations, that there's a clear way that under a program of care that there's different opportunities globally to do different activities. So the chat's open. We really want to know, do you know of a hospital or a healthcare provider in your country who you think that, you know, our hospital would just be doing ECRD in Sweden, so in Gothenburg or the Karolinska, they would be a global hub. If you know of your centre is an expert, a lighthouse in rare diseases, put it in the chat, because we want to try and map that at the moment. We've been engaging, and I'll show you a timeline of the work which we'll carry on doing this year with RDI members. This is very much an at the moment. The vision of the Global Network is a sketch, and we're trying to breathe colour into this, breathe life into this from your perspectives based on your needs. So at the moment, we've started to identify from the feedback so far from the webinars we've done, some key feedback, and we're using that to change how we do the components of the Global Network. So an example here, on the last webinar, we were told that national policy is really important to promote rare diseases and universal health coverage. So we want to include that as part of the endorsement. Endorsement should be within that framework. And therefore, for centres wanting to put forward, we're trying to move forward the situation locally, politically. I won't go into the details on here, but the slides will be available. I think it's important for you to see we're listening and we're changing the model as we go forward. I mentioned about patient members being key. So number one, we think that they should also have a national or international population they serve. They should be recognised as their competency as being advocates, and they should also be endorsed by their board to take part. So it's not one individual acting, it's the organisation taking part. And we think that there should be some standards and a way to manage entry in and out of the Global Network from the patient side as well. But patient organisations need to do something and be active within the network. So we've been very clear, and we want to be clear about the role. Whilst we all recognise patients are experts by experience, patient organisations, we think that the key role, because this is about improving access to quality care and diagnosis, is that the role in the Global Network is to support your vulnerable groups and isolated populations to be able to access care. So working with those global hubs within your country. Also to build capacity building and promote health literacy and be that bridge between network discussions and the community. So we've got a poll. Could we?
Hi, Matt. Yeah, I'm ready to run the poll.
Thank you. Shawalani, I get it.
You're getting there.
Yeah.
What should the key activities and functions of a global network for rare diseases be? Choose your top 3 priorities. Develop rare disease competencies in the national health systems. Make experts visible and signpost patients. Support the development of an official recognition for rare diseases. Experts offer acute advice and organization of care in patient crisis. Develop diagnosis tools and best practice. Collect data and benchmark outcomes of care. Exploit advancement in technology and innovation. Develop new best practice and innovation through knowledge sharing. Offer training and education activities. Support clinical research and activities. I'll give you guys a few minutes to think about your responses.
Thank you. So while you're giving those feedback, I'll carry on, and please give me the results when they're available, if that's okay.
Will do.
So in terms of the project, we need to, as Jan pointed out, the Memorandum of Understanding says that we need to come up with a needs assessment study, which outlines a conceptual model and the methodological framework of what a global network is and how centres can apply. So this project then is over 5 years. This year it's a discovery phase, which we do that needs study. Next year we do the methodological framework, which is the development phase. Then we'll use that methodology in the year 3 to do a call for applications, and we'll do the assessment, and those centres which come forward will then pilot as a global network in year 4. Are the results in?
Yes, the results are in.
Yeah, super.
Here we
so
go.
I'll just pause. Super. So obviously the highest one is to develop the national competency in terms of rare diseases. And the next one is around benchmarking outcomes of care. That's great. Great to see that that's moved quite high on the list. And supporting the official recognition of rare disease. So rare disease plans being part of the endorsement, I think would be part of how we achieve that. And education and training. So education and training scored less than I thought. That was quite interesting. On the previous calls we've had, we've been told that that's really quite a high importance. And research is quite low as well, which is quite consistent with what we've got so far. So we use this feedback, which has been really great, when we come up with, next year, when we start designing the methodological framework, we need to set standards for centres to meet, to join the global network. We'll use those areas to be able to structure how we develop those standards, those operation criteria. So this year, the discovery phase, we're doing 3 activities. We're doing a literature review to identify the evidence base for networking. We're doing a needs study on a selection of reference cases to identify population needs. And we're doing semi-structured interviews of existing networks to be able to then gain insights of what works, what's the added value of the existing networks like RDI or the ERNs or NIH, and see how they structure themselves and their characteristics and the services they provide and what the feedback from the community is. So the knowledge, the insights, the needs and the evidence will be used then to shape something called a concept model. And that will describe the what the network should do, and how this, the hub model will be structured. And then next year, we'll take that concept model and we'll turn it into a more detailed framework. So this will be a bottom up. So instead of looking at a global network and networks which are in existence looking downwards and global needs, next year we'll be mapping the potential hubs, going to do on-site visits, seeing about their competencies based on the needs which we've identified in the needs study. How do they meet the holistic needs of those conditions, to see how ready those hubs are in participating in a global network. And of course, looking at the existing assessment processes which are in place and designing something around eligibility, application and support tools, but also the assessment process, criteria and standards. So that work will be done next year. This year, the output of this year will be 2 documents: the concept model, which will be the what the network will do, what the hubs will do, what the patient members will do, and the how. Who's the decision maker in the assessment process? What's the process for assessment? I mentioned a bit about needs. This should be through, we want to approach this through the needs of people with lived experience. So we want to do the survey this year of a number of selected reference cases on cluster of rare diseases, looking at function, health and disability using the WHO international classification. So an example could be, we could identify Duchenne muscular dystrophy as a reference case for neuromuscular and movement related disorders. Functions, and collaborate with the International Federation to survey their members to see how how needs are different in different parts of the world. We'll use that learning from the different reference cases from the survey to come up with a balanced scorecard, which will be used when we do visits next year to hospitals. So instead of saying, well, what expertise you have in your hospital, we want to see how they meet the holistic needs of people with these under these different clusters. And lastly, we'll use that the visits to do a baseline competency of where the expertise is around the globe to be able to develop the assessment standards which will be used for application. I mentioned about looking at needs and clustering by function, disability and health. So this is the WHO classification. So we'll be looking for a reference case for each one of these clusters to be able to do a survey, and we'll be engaging with RDM members for that. Last slide. We have a number of webinars this year. So you can see here, the next thing we'll be doing is some focus groups based in the different geographical WHO regions of RDI members to identify needs. To test out some of these concepts and ideas around what a hub should do. Does that model work in China versus North America or Australia, etc. By August, we're looking to present the results of our literature review, and I think it might move to September, to be honest, and we hopefully share the results of our survey. October, we'll be looking at sharing the insights we've gained from the interviews and what the concept model will look like. And the final piece of work will be submitted to RDI in terms of November. So I think that's it.
Thank you, Matt. Thank you. That's really great. And it takes more than one time to really grasp on this presentation where there is so many important information and concepts and terminology. And so, but I can see from the chat that there is a lot of conversation going on and a lot of interest with concrete elements brought forward. Thank you very much. And without any further ado, because we are over time, I'm turning to Anna Rath, and we come back to you at the question time. So Anna Rath is director of ANET, and you know Anna from previous meetings of RDI when we had the meeting at the UN and also in Geneva, if I'm correct. In fact, why are we working with Anna on the topic that we'll discuss now? Is not only because of ANET and because of Anna herself, but because also ANET has been the secretariat to support a group of experts to work on the classification of rare diseases in the context of the revision of ICD-11 some years ago. And so all that is already somehow in the pipeline of WHO. So there is a strong rationale for RDI and ANET to come together when it comes to this topic of definition of rare disease. The floor is yours, Anna, to explain where we're coming from and the perspective on that. Thank you very much for being with us.
Yeah, thank you very much. Jan, can you hear me well? Yeah.
Yes, very well, very well.
Okay, so super. So I will share my slides and I thank you very much, Duran and all the RDI colleagues. And tell me if you see the slides. Yes. Can you confirm you see the slides?
We do. We see the slides. Go ahead. It's perfect.
Perfect. Perfect. So yeah. So we, as Jan told before, we are working together from a while now on this matter of the definition and of the data that we a global, a common definition could allow us to gather. And we started working on this article that most of you maybe know, try to estimate how many patients are out there in the world suffering from a rare disease. And to do that, we exploited the ORPHANET database of epidemiological data, and we co-authored that together with Urodi, so with Jan, in order to give, to make these figures talk and to give a perspective that is the one of this strategic agenda that RDI has. So we discovered some results by doing this exercise that is, I insist on the word estimating because it comes from the literature and not from real world data because we don't have a good data and precise codification of patients enabling that, us to have this data. So out of this estimating prevalence and patient numbers work, we saw that the big majority of rare diseases are very rare, and that what you have here in green, that the vast majority of the people suffering from the rare diseases, so more than 28%, have one of the around 400 most prevalent rare diseases. What is happening with the animation? So it's not working. But as you see, the majority of rare diseases are very rare, and only 2% of all the patients have one of these 90% of rare diseases. So they are the most vulnerable population. If we set strategies, as Matt presented already, based on the more prevalent rare diseases, we still are managing a place, a home, to these most vulnerable patients that are really very scattered over the world. And I would like to say, is towards them that we need a global network, because the expertise for them is really very rare and is really scattered over the world. So we need to connect all these centers that are shaped for the most of the people, most prevalent rare diseases, in order to also tackle the problems of the most vulnerable people, in order to leave no one behind. But if we look at what happens in the world, we see that because of the vast majority of diseases are very rare, even the most, let's say, constrained definitions based on prevalence over the world cover the vast majority of diseases. So the list of disease is very overlapping in different parts of the world. But when it comes to patients, we see that the definitions based on prevalence that do not cover the most frequent rare diseases are not covering the majority of rare disease patients that are included in other prevalence definitions. So we have this definition problem that is that has two sides. One is the concept of what a disease is, and the other side is which is the can we have a common ground on the prevalence of rare diseases, and that is maybe not necessary, so as we will see. The thing is that we need anyway a standardized definition in order to have a common language, as we will see, and to know how many rare diseases are there. Because to make this publication, these estimations, and to count how many patients are suffering from rare diseases, we needed to start by defining what we would count. So we took an option for defining what a rare disease is, but this conceptual definition is maybe not shared in every places in the world and in all the settings. So there is this paper that we co-signed, so a big consortium of people signed for this call for have a conceptual definition of what a rare disease is. Because when you put together many terminologies, you have more than 10,000 rare disease related concepts or terms, but do we have more than 10,000 rare diseases in final? For that, we need to agree on concepts. So we face the problem, how to define a disorder. So a disorder, rare or not rare, it's a concept, it's a view of our minds that is really multidimensional. We can see the same object from different perspectives. And a disorder is also an object that we can isolate from something that is a continuum. And a lot of people try to define what a disease is without having succeeded, and that is from a long time now. But we need to take an option. So I like to bring this, let's say, optical or photographic metaphor that is that defining a disorder is to adopt first a point of view, so see one dimension, and then when you have chosen that dimension or this point of view, to make a focus on the level of interest for us. So you see here the same group of diseases, the same family of diseases from a clinical point of view. So you can say that classic congenital adrenal hyperplasia is a disease belonging to a group of congenital adrenal hyperplasia that are endocrine disorders and that have different clinical subtypes. From a clinical point of view, you can name these diseases that are reflecting the problems that a person is having. But if you adopt an etiological point of view, you will end by CYP21A2 mutation. And that could be, and that is the name of the disease from a genetic perspective, but it's not covering exactly the same clinical picture. So it's covering different parts of different persons. So the thing is that we do need, in order to have a common language and to talk each other and to share data and then to gather data and indicators for the future, is to define our point of view and our focus of interest. And it seems to me that our common interest is to leave no one behind. So for that, is the reason why we adopted for this paper and in our nomenclature a clinical definition, because we need to give a name to a disease that a patient, a person can hold, can name, and can, let's say, take for him or herself through all the pathway he needs or she needs to cover. A healthcare pathway by a real life pathway. So each person deserves a name for his or her rare disease. So we need this common language. But that is why we have adopted this clinical definition, because for us it's the more inclusive one, because it refers to what the patient has and what the doctors see, and that is independent of the knowledge we have on this disease, of if it is genetic or not, of the gene is known or not, is really the clinical picture that is homogeneous in at least 2 independent patients, so really covering even the most rare diseases. And our epidemiological study is based on that level. But having defined this level, we can still accommodate other points of view. For instance, the subtypes based on genes, or the groupings in order to aggregate data for comparability between countries. So it's really setting a common definition to have a common language, to make patients visible in order to take action. So really we need to generate data to measure the population burden, to have indicators in order to evaluate if the health policies are effective or not, etc., etc. And adopting this type of classification system allows to have a common thing that is cross sectors, that accommodates the needs of the point of view of the researcher, the geneticist, the carer, so the doctors, but also the public health by aggregating data that are coming from different sources. That is why we are delivering these ORFA codes that are not adopted everywhere in the world, maybe it's a dream, but that are also mapped to other terminologies in order to allow for interoperability across different parts of the world. So for us, a definition, independently of the definition of the prevalence concerns, we need before a consensus, because there is no universal definition. We need to agree on that. And for that, we need to reach a consensus on a concept behind what we call a rare disease. And then we need to recognize that that could be different prevalence thresholds because it depends on other considerations. But at least we will have an agreement between all the points of view in order to have this common language. So maybe I give you the floor, Jan, to comment on this.
Yes, thank you very much, Anna. So just to make the link to the members who were at the General Assembly of RDI yesterday, there were that same slides, and for the others to understand. So the way we're taking this activity for the year 2020 is that the objective is that by the end of the year, we will have a document adopted by, endorsed by WHO Secretariat that will provide this approach as Anna just presented. For that, we're putting together another group composed of some faculty experts of RDI. In Orphanet, in conjunction with WHO and RDI, will also identify experts around the classification to bring back into these discussions. And we will also engage all the members of the RDI Advocacy Committee. And will be also probably presented at some point to all members before final adoption. So that gives you a sense of where we're going with that work. Thank you. So now I yield back to Panama.
Okay, I will stop sharing.
Thank you very much again, Anna. Paloma, do we
Okay, so we have, we don't have a break anymore. I think we do actually. We will come back in 10 minutes and resume our discussion onto the third session, which is working with the WHO to improve access to rare disease medicines and diagnostics. So we will be hearing a presentation from Jan and then another one from IPOPI regarding this topic that got a lot of interest yesterday at our annual General Assembly. So let's reconvene in 10 minutes.
Thank you, Paloma.
Okay, so we're all back from the break. I hope.
Yes.
Yes. Well, we've seen a lot of positive feedback on those two actions of the MOU of RDI with WHO. So thanks for all those comments. I haven't seen any particular questions, so I think we can go straight to our third session with Jan's presentation.
Very good.
Yeah.
Coming right now.
You want me to share?
No, I'm sharing them normally.
Okay.
Do you see them? No?
Not yet.
Okay. Then I go there. Do you see it?
Yes.
Perfect. Let's go. Yes. Okay. So that's an introduction on the WHO Essential Medicines and In Vitro Diagnostic List. So first time, in fact, that we discussed that in RDI, if I am correct, and it's on our action plan for the first time. So we'll give a first introduction and then Johan Prevost will come to present their experience as a patient organization, both on medicines and on diagnostic. So what these lists are, there are three lists: the list of essential medicines, which is the best known, the list of essential medicines for children, and the list of in vitro diagnostic, which is more recent. It started in 1977, and more recently, there were 460 products included on the list, including now some of advanced therapies, advanced drugs like in cancer. Around 150 countries are in fact using this list to define their national priorities in terms of coverage and provision of these medicines. So this is where the utility of this list is. So it needs to be clear for the one who would not be yet familiar with the concept of WHO priority list, is that it's not because a product is listed in this list that it is available at national level, not at all. It's simply that it is recognized as a medicine which is a priority, which should be provided in any national context. So that's something that then locally, the medical professional, the hospital directors, the patient groups, whoever can say, hey, it's in the WHO list, we want to have it in our country also. So why it is important is that it provides this kind of guidance I was just saying for the member states as a reference to make their own decisions of what they should prioritize in their limited budget. But it's also, from a patient advocacy perspective, a way to refer to that list to advocate locally in an hospital, in a city, in a region, or in a country to have access to it. Also, and that's not to be neglected, from the moment it is on the list of the WHO, it is then included into the work of different parts of the United Nations system, like the development programs, or in UNICEF, or in the High Committee for Refugees, etc. So that is also an important element. The overall, what's also evolving is that it reflects the change in the therapeutic options. So we're not anymore only with the antibiotics and other type of medicines of this sort. We are also now with therapies which are more advanced, and particularly in the field of rare disease. From the moment we have therapies which are potentially curative, there is a new interest of WHO for these treatments. The WHO assess the quality of the drug, review the different clinical trials that have been done. So there is an overall quality assessment, qualification by WHO. So there is different units of WHO intervening in that process. Sorry, I'm just checking if I'm trying to move fast. So just to refresh, in 2006, so it's not a century ago, right? It's 14 years ago. There was this kind of definition already that was saying that if the definition of an essential medicine is to be changed to include medicines needed for people with rare diseases, then the principle of distributive justice can be the moral basis for such a change, and cost effectiveness analysis can be the method used with these medicines. So that's 2006. 2006 was also when a report of WHO on essential medicines was in fact making a lot of confusion between neglected diseases, rare diseases, orphan products, etc. A confusion which has messed up the situation for years after that. But still, this period that was 2006 in this quote from Reidenberg, you see now at the time of adoption of universal health coverage, the ambassador of Thailand, and you remember that Thailand was the leader at the General Assembly with Georgia, they were the two countries leading the process for adoption. This is what he said in a meeting: we must work together to ensure equitable and affordable access to quality health services and medicines for everyone. So, and particularly people with rare diseases. So we can obviously leverage all that. So concretely, the process of essential medicines, and that will be illustrated in a moment, is that there is a list, there is a group of experts which review the applications, there is process for applications. So for instance, the next one, right, the next round is for the end of November 2020, and there is a WHO expert committee which will be meeting from the 22nd to the 26th of March 2021, to be confirmed, but roughly it's that. And these meetings, or part of it, are open to the public, so we can, or selected public, so we can participate to it. The most recent version of the list you can find on the WHO website, or maybe it's already provided to you through the documents of RDI. So now I move to the in vitro diagnostic. The list of in vitro diagnostic, it's a more recent concept. It's only in 2018 that it really started, the implementation. And it was to cover initially the high priority of infectious disease and HIV, malaria, tuberculosis, hepatitis, but they very much welcome rare diseases. And our initial conversation with them were from early 2019, and they really welcome us. So now there is over 60 types of in vitro diagnostic, which are being studied by them. The second edition was published in July 2019. At the moment, they are reviewing additional tests, so it has growing success. But we know also that at the moment they have revised the priority to focus on COVID. But the fourth cycle of submission is July, August 2020. So the revision will be then in March of the following year for 21 for the fourth edition. So that translates. Maybe I jumped directly to the way we're approaching it is that for this year, the way we're approaching it in our activities is that we consider that we're doing our homework for now, not more than that, but homework. So we want to do two webinars, one with the staff of WHO on essential medicines, and one from the staff of WHO on essential diagnostic. So two webinars, to our members and to the faculty experts, so that to present and also to engage them with us, to starting to recognize and engage publicly about rare diseases. Then we will do two webinars on case studies, like today with Johan. We will do other case studies based on what has succeeded or what has failed. In parallel, we are forming within the expert faculty of RDI a group of members of that faculty expert to become our champions on this topic, to bring their professional experience and knowledge, to help define where RDI can have a role, but also to help the members of RDI to develop their applications, and for us to liaise with you, obviously, always with you, because it has to be you to do it, with your clinicians, with the companies developing this product, or with the hospital. It can be either a patient group, an institution, or a company developing the application. But we want to gain experience, we want to gain knowledge of how the system works, we want to learn from the first experience already existing, and we want to build a body of experience from helping our members applying. And through these different expertise, we will become more experts progressively, collectively, to help more rare diseases to push their essential, what they think are their essential treatment medicines, but also diagnostic tools. So that's the approach. And maybe I've not insisted enough on the medicines, but what's changing, that's recent. It's only 2020 that before, for essential medicines, they were looking at the size of the population. Now it's not the size of the population only, it is any type, and maybe I can go back to that slide quickly, because maybe I should have insisted on that, is that before, yeah, you see it's the fourth indent, only going with the population size. But today, the objective is to have equally relevant high, middle, low-income countries access to new, highly effective, even if they are expensive medicines. But because WHO want also to use, after that, it's another step, but potentially joint procurement. So that's the kind of ground that we're laying with this work. And the purpose of it overall with this action plan is to help more of you to develop applications. Here you have 3 examples, and with that, I now leave the floor to Duran to introduce Johan. Thank you.
Thank you. Thank you very, very much. And that was a real tour de force to take us through what is hopefully going to be a very important initiative. So based on what Jan has said, you can imagine, the value of having a medicines for rare diseases, or as importantly, a diagnostics for rare diseases, as part and parcel of what the WHO is providing on their list, but also the opportunities for being able to use that to provide access. So we're really delighted to actually have Johan Prevost, who is with the International Primary Immunodeficiencies Organization, IPAPI, who is going to share their experience with getting successfully a diagnostics on the WHO list. And I think it's both an inspiring presentation and also one that can give you some sense in terms of the amount of work and collaboration it takes. So thank you so much, Johan, for sharing this.
Thank you very much, Doreen and Jan. So I've got 15 slides for 15 minutes and 50 years, 15 years of experience with the WHO list. So let me try to share my screen with you and we can get going.
But I hope that's just the beginning, Johan. Next time you will have 15 hours to go through.
Well, I think that'd be very boring. Okay, so well, thanks again for having me. I thought I would start with a very brief introduction on IPOPI, just in case some of you on the call don't know who we are. So we are the International Patient Organization for Primary Immunodeficiencies, and primary immunodeficiencies today represent 416 rare disorders, so quite a significant subgroup of rare diseases. And you can see that our mission is all about our dedication to improving awareness, access to early diagnosis and access to care. And of course, with these two last objectives, the work we have done with WHO is very important. And this is just another slide showing you the same objectives. Just to give you a little bit more detail of who we are today, we represent currently 68 countries. You can see the map of the world here. Every country painted in orange is a country where we have a national member organizations, and you can see that most recently we welcome Nicaragua, Tunisia, China, and Kenya, so very international scope, and so is the scope of our work. So if I now go over our collaboration with the WHO over the last few years, we've been particularly involved on 3 levels. Because of our patients are treated, a majority of our patients are treated with plasma-derived medicinal products, we have been very involved with the WHO on the activities around the topic of blood safety. We were a member organization of the WHO Global Collaboration for Blood Safety for a number of years. And we have also been very active on the model list of essential medicines, both for adult and pediatric patients, as well as more recently, the in vitro diagnostic essential list. And this is what I will focus my presentation on today. So I won't spend too much time because Jan very eloquently went through the top lines of what these lists are. Just perhaps to add, besides the fact that you have an essential medicines list for adult and one for children, you should probably know that each of these lists is actually split into 2 sections. You have a core list, which include the minimum medicine needs for a basic healthcare system, and then you have a complementary list for essential medicines for priority disease, for which specialized diagnostic medical care or specialized training are needed. Jan very rightfully mentioned that more expensive medicines have been increasingly considered by the WHO. This is certainly the case for us and immune globulins. So to tell you a little bit about our story with this list, the first list was published in 1977, as Jan said, and I think that pretty much from the early years, 2 plasma-derived medicinal products were included: coagulation factors for hemophilia and immunoglobulins for primary immunodeficiency and Kawasaki diseases. And in 2003, it sort of took everybody by surprise. What happened is that actually the WHO removed immunoglobulins from their list. I don't know whether it's related to some of the elements that you've described and all the discussions that were starting to take place around the mid-2000s, you know, around rare diseases and so forth. But the reasons we were given at the time for withdrawal was that there were no WHO clinical guidelines recommending the use of immunoglobulins for primary immunodeficiency, and there was no need for them in view of availability of suitable vaccines, which obviously for anyone working in our sector is not really a valid argument at all. And so that means that you know, this decision yielded a lot of stakeholder organizations, including IPOPI, to react immediately to the decision, try to appeal to the decision, and many letters were sent and arguments were developed, but to no avail. And the initial individual efforts to reinstate immunoglobulins in the list were unsuccessful. So we were not able at the time to get immunoglobulins back. And in 2005, the WHO provided us with the reason for rejecting the reinstatement. They were saying at the time that the prevalence of the target diseases is very rare, that there is insufficient evidence of its efficacy, and that there is insufficient evidence of its cost effectiveness. And so that led us to really ask ourselves, what did we do wrong? Because we thought we had the right arguments. And we started to ask ourselves, well, are medicines less essential if they are medicines to treat rare diseases? And if that's how the WHO views it, perhaps there's something we can do to make sure it's no longer the case. We also knew we had quite a number of good data on the efficacy of immunoglobulins. And we had good arguments and good patient surveys showing that treating the cause of the symptom rather than the symptoms alone is actually a cost-effective way to approach it. And so these reflections form the basis for a more, I would say, ambitious campaign. We realized that actually what was needed was a united voice rather than every stakeholder involved sending separate applications, approaching the WHO from different angles. What if we do this together? And so this is how we decided to do a joint application submitted by IPOPI and IUIS. So IUIS is the International Union of Immunological Societies. They basically represent the experts in the field, whilst including all of the others who had expressed concern. So all of the other organizations were included in this application, but they were included as supporting organizations. And I have to tell you, the application document in itself is already quite a detailed document. It includes a lot of information from proposed formulation, dosages that you should propose, to what regulatory processes are in place. Are there additional standards such as pharmacopoeia standards that are in existence and that you can demonstrate in your application? And in addition to all that, you have a number of annexes. Well, at least we had a number of annexes with detailed lists of scientific articles classified along the different categories and criteria requested by WHO. So it was, I have to say, a very long process to prepare. It really required, patient organizations and doctors working together, making sure we had the expert know-how as well to feed in all of the scientific information that we needed. And you can see on the slide that we had, others as well. We also had some industry associations that wrote support letters. These were included. We also had a call for action from the top international experts from many countries. And importantly, and it's not mentioned on the slide, we actually obtained an audience at the meeting of the expert committee in Geneva. And we went to that meeting with a representative from the doctors and a representative from the patient organizations. And actually, we had both the developing world countries and more developed economies also represented through or two representatives. And to this day, I think that having this dual approach is probably what was the last piece we needed to be successful. And so it was the case that in 2007, immunoglobulins were included back in the list. So when in 2018, we learned that the WHO was looking now at publishing a list of essential IVDs, diagnostic tests, we took the view immediately that that was an opportunity to actually bridge that gap between diagnosis and access to treatment. And our philosophy was, if the WHO makes recommendations on what should be the essential medicines that a country should have in place, including for some rare diseases, surely they should be open to including rare diseases in the scope of their diagnostic list, because the first step to care is a proper diagnosis. And it's certainly very true for primary immunodeficiencies. We know that the diagnosis delay, like many other rare diseases, can be quite significant. And so that required, again, quite an important internal effort. My colleague Leire, who is on the meeting today, has been absolutely a star coordinating our application. And she dedicated a lot of her time to coordinating the dossier, to liaising with the WHO EDL staff, whom I have to say were very receptive, were very helpful. We had some communications forth and back with the feedback of the reviewers. But of course, beyond involving IPOPI's time, we also had 3 volunteers, medical experts involved in the process. We had also laboratory staff members involved in the process, because there is such an amount of evidence that you have to provide. And I have to say that for in vitro diagnostics, sometimes it's not as obvious where you're going to find the evidence than perhaps with treatments. So it was a massive effort. Again, we took the same approach. It was an IUIS IPOPI joint campaign. We had several international scientific societies and researchers networks, as well as industry associations, again, supporting the application. And well, I'm pleased to say that we were successful. Again, I believe PIDs are the first rare diseases actually to be included in the EDL. This is also because initially I don't think WHO had planned completely for inclusion of rare disorders, but as Jan has stated already, I think this is changing, and certainly the fact that PIDs were now included is a good sign, I think, for the rest of the rare disease community that actually it can be done. Now, when we talk about essential in vitro diagnostics, of course, one thing you have to know is that when it comes to the diagnosis of primary immunodeficiency, you have several types of diagnostic tests that are involved. And we decided to actually go for the more baseline tests to start with. We thought it would increase our chances to get them in. It worked, and right now we are actually working on additional tests to be included for the upcoming list. We had been invited by the Secretariat of WHO to attend their meeting in Geneva again, which was due to take place actually, I think, in March of this year. And of course, it has been postponed because of the COVID-19 pandemic. So why do they matter? And I'm getting near the end of the presentation. Well, as Jan says, it's very important to realize that these lists can then become a platform or a document that you can use at the national level. A lot of countries will actually adapt the WHO list to their national setting. So what you will find is that you will have national list of essential medicines. They don't always match the WHO list. And so, part of the game is to make sure that doctors, patients, and any other stakeholders that has an interest and may be able to help get together in the same way and advocate for for access to diagnostic tests and treatments. So it's an excellent awareness raising tool as well, these lists, both for the EML and the EDL. Certainly, in our view, the EDL has the potential of facilitating the diagnosis of PIDs, even by non-specialists, and so that could broaden the impact. And moving forward, we think that the link between both lists will be strengthened in future edition of the list by WHO and in country assessments as well. So this is my last slide. Lessons learned, I guess. It's feasible, but be prepared to, take some time and be really involved in this exercise, because it is a time-consuming exercise. It will really require dedicated resources to be able to do it. The WHO guidelines and requirements need to be followed. That's my alarm telling me I should stop speaking. Okay, good. I will stop soon. So the WHO guidelines and requirements need to be followed really to the letter. That's another thing that's very important. Don't dismiss the details. Make sure you abide by what they ask. And of course, it's just the beginning of the advocacy, and the implementation at national level is really what will matter at the end. So that's it for me, and thank you for the opportunity to speak today.
Thank you so very much, Johan. As I think we indicated before he spoke, be prepared for the fact that this is not a trivial exercise, but huge congratulations on both of those cases. I think are we having a poll first before we have questions for Johan and Jan?
No, there has been a change in plans. There's no poll, but we have time to take questions.
We do have some questions. Okay.
We have time, 20 minutes.
20 minutes, okay. So certainly we can have other people share any other experiences. Can I ask you, Johan, given what you've said, what happened? Well, number one, when you brought back the IGs into the essential medicines list, was there any kind of response uptake in terms of different countries? Were you able to, or did any of your members actually able to use that to press forward in terms of access? And what about the in vitro diagnosis? Are there specific plans in terms of where this might be helpful, where they were not available before? I know it's a big global question, but I'm hoping that you can kind of even provide some examples if there are any.
So it's, we're still working on the EML, and it's been 15 years. So again, this is why my last slide said what it said, which is that it's then up to each country to start lobbying. It's not because your medicine is included in the list that automatically it's going to get reimbursed everywhere. In our case, we know that an average primary immunodeficiency patient on immunoglobulins, it's probably 20 to 25,000 euros a year, which is not an insignificant number. And if you look at that in the setting of some of the developing world countries, obviously that's quite a commitment. Even in countries like Europe, we still see divergences, but it certainly has had a tremendous impact in some countries. I will always remember a mother from Bosnia coming to us a few years ago to one of our meetings, and subsequently she's actually become the first chair of the organization in the country. But she had actually obtained the reimbursement for immunoglobulin for her son based on what we had done, based on the inclusion of immunoglobulins. And that was just, one passionate patient advocating, using the tool. So we've had other countries, obviously, using the WHO list to try to get reimbursement and access to immunoglobulins. And increasingly, we're seeing these medicinal products being reimbursed. The reimbursement, again, will work at different levels depending on which country you go. A country like Vietnam will reimburse, for example, up to age 18, and will only have partial reimbursement for a number of these years. So, all of that's just the long battle of fighting for access and coverage. But our experience shows that the list is definitely an asset in these sort of advocacy efforts.
So thank you very much. I think Dennis was asking somewhat of the same questions if there were specific examples. So appreciate very much your bringing up, especially with countries that, as you say, may be prompted to expand their access when it's on an essential medicines list. A question here from Rasha says, what's your advice for advocating access for new medicines for the neuromuscular diseases, you know, MD, SMA, Duchenne, when there are huge price tags? So trying to get them onto the list, you know, is there a rationale for it? Is there a specific case that can be made?
Well, I think again, I mean, I realize that, you know, I said all treatments are expensive. There are treatments that are way more, you know, expensive than that. I mean, certainly part of how we played it at the time, and again, I think the times have changed. And I think what Jan says is quite important, that the WHO now has probably a different angle than they had when we were working on that. Certainly at the time, what helped us is the fact that PID was not just one disease, that it was already a group of disorders. And we could actually make a case that despite the fact that we represent rare immune disorders, if you take them as a whole, they represent a significant portion of people. And that did play in our favor, I think, at the time. But again, look at hemophilia. I mean, hemophilia, you know, more expensive treatments actually than PID. You know, they're in the list. They probably wouldn't be able to use the same argument. So I think it can be done. I think it's just perseverance, making sure that all the data you have available, you show it, that you work with your doctors. I can't highlight enough how important that is. I truly believe that if we hadn't done that, we wouldn't have been successful. So you need to have that scientific and medical backup to your applications. And you know, I'm not saying it's not going to be an uphill battle. I mean, look at us. It took us 4 years to reinstate immunoglobulin. So it wasn't easy. I probably can say that when it comes to the IVD list, although again, it was a very time consuming, probably because we had some experience, you know, running these sort of campaigns with the list of essential medicines. You know, we were successful at the first attempt, and that's also perhaps an indication that the open-mindedness of WHO is there, you know, to widen the scope of the list to rare diseases. So I think there is a momentum that can be used, but yeah, be prepared to fight for it and make sure you align with the right stakeholders.
Thank you very much. And hopefully, Johan, as we're moving forward, as Jan talked about, you know, hoping to do some webinar in terms of making the process more accessible to people, that an expert like yourself obviously would be available to help provide that overall guidance, not committing you to do hand-holding on a group-by-group basis, though I can see a whole bunch of hands kind of coming up. I'm sure you've got your work cut out in terms of what you're doing, but I think it's an important lesson. And certainly, I think as we're talking about, quote, expensive medicines or complex medicines, I mean, IG and the clotting factors are in some respects a fairly straightforward medication. Mm-hmm. I think we've seen, as you say, the WHO moving towards, and certainly in their last listing with the cancer medicines, more complex medicines. So being able to consider as essential, not just what is essential, as you said on one of your slides initially when IG fell off, that prevalence was a defining factor. There seems to be that openness to saying we cannot just be limited by, you know, what are we talking about in terms of large population. So I think the more we do it, the more that we will get that kind of acceptance. And I don't think any of us are suggesting that people just do it for the sake of doing it and to open it up. But I also know, as in many other cases, if nobody does it, if we're daunted by, you know, the work, even if we're not successful, that it will make a big difference. And certainly I think learning from each other in terms of how to do it, I think is a hugely important activity. We've got a couple minutes, and I'm just going to beg the indulgence to also a couple people mentioned and Jan mentioned at the end, you know, ERDIC's efforts on a working group for access to treatments for all. And we're seeing this as very much of a coordinated effort to try to maybe, beyond just being on an essentials list, to also think about what are the barriers to access across different countries or different regions as well. So this effort is also just undertaking. We've got some of the patient organizations within RDI that are part of that initiative. So we're very excited about that, including other clinicians, scientists, et cetera. And certainly, we are looking for some of the international rare disease organizations to join us, because you folks are the ones that have the experience of having, to try to work with your, member organizations in different countries to try to get that equity of access. And I think you've had some both successes and obviously some real challenges with regard to the different kinds of barriers. So I think this will be an important opportunity. We heard it yesterday as well, the concerns around the fact that you may actually have even programs, and I think Dennis mentioned it yesterday, that are bringing these medicines into some of these countries where there may be political conflict, where there may be corruption, and then the medicines don't get to people. And we've got other cases where the medicines could be available and in fact could be donated, but the regulatory barriers in terms of getting them listed are such that we cannot get them there. So I think we do want to, kind of make sure that we're having medicines that are going to be considered essential, from a variety of sources, but also looking strongly in terms of what are the barriers, what are the facilitators in terms of access. Because I think, as you've said, and I think as Jan in his presentation there, getting them onto an essential list is oftentimes, an important first step and an important leverage. But that certainly is no guarantee that they're going to make it to people. I think it's an interesting question, though, is, what about, an expensive medicine? Or are we suggesting that, groups look at, medicines that may already be, there? They may be medicines that are already being used in other kind of areas, but they're not listed as essential for a particular rare disease. Is that a better pathway than to consider some of the more innovative medicines that obviously have a huge price tag?
Do you want me to comment on that?
Well, I wouldn't mind having you comment on it.
I think it's certainly, again, I think what we need to focus on is whether these expensive medicines fulfill an essential need. And I think, that's your starting point. The cost effectiveness, it's a part of it. Perhaps I didn't mention the fact that when, cost effectiveness was one of the criteria that we were judged on when we put down our application in 2006. And I can tell you honestly that, we didn't have that much on cost effectiveness. We had one or two articles out there that, made a point. We had good patient surveys. So we had good patient surveys that demonstrated the benefit of having patients on treatment versus treating these patients for their symptoms and really treating the cause. But that's not a proper pharmacoeconomic analysis. So we didn't have a proper pharmacoeconomic analysis, but we were able, through the patient experience, to have a convincing argument that it should be done, and it went through. I think a little bit of it is also the sort of political push that you can have. The fact that we got an audience, that we got the right people in the right room was very important. I think when it comes to RDI, you are very well placed now with everything that you've done on the UN, with the APEC. And by the way, the APEC, I mean, we are as involved. And for example, we contributed to the guideline on safe and efficacious coagulation factors and immunoglobulin from APEC. And we actually leaned on the WHO EML to do that as well. So I think, each piece is a part of the puzzle, and you certainly have placed RDI in a good position with regards to the WHO. So I do think there's a momentum. Now for individual, medicinal products, that will be up to RDI members. But I think with your experience, you can certainly guide them. You can certainly light the way for more rare diseases therapies to be included.
That's a really good, I think, statement there, because it also does help us, as we say, RDI collectively, to be able to support individuals. We do need to have the individual organizations or diseases that are making the application, but certainly we can also learn as RDI in terms of how to help it. A comment here from Godfrey from Thalassemia Foundation Ghana, and welcome Samuel to the panel. So lovely to see you. How great. We're delighted that you not only were made it here, but we've got your smiling face as part of the panel. So looking forward to you in the next session here. He says that thalassemia testing is very expensive in Ghana, and the management of sickle cell disease is really hard. Can the medicine costs be subsidized and HPLC device be supported? So this again goes back to, you know, it's one thing to have, you know, the treatments or even the devices as deemed essential. The challenge is, how do we get, you know, the reimbursement? How do we get the support? And I think, you know, obviously, you know, I don't know if, you know, there's obviously no easy answer to it, but I will say that we were very inspired in our panel recently, you know, when Raquel Peck, who was the past executive director from the hepatitis, you know, the Foundation or Society International Hepatitis, spoke about their experiences in terms of getting hepatitis treatment and hepatitis recognized by the WHO and becoming a significant force. And we know that when the hepatitis C therapies first came out, they were considered to be exorbitantly expensive, and they still are, and really challenges for even the well-developed countries and really well-funded health system to embrace. And yet with the collaboration of the WHO and the designation of these hepatitis C life-saving curing therapies to be considered essential, huge pressure placed on the manufacturers to actually make them cost-effective and to make them accessible. So I think that's the other part of it. You know, if they're deemed essential, what are the other kinds of mechanisms that can be brought into place to help offset the cost of some of these medicines in the low and middle income countries? And we certainly are a long ways from where something like a Gavi Alliance can help subsidize the cost of vaccines. But I think somewhere in that vision, right, is an important first step might be the fact that this is considered an essential medicine. Now, how do we lean on all stakeholders, including the manufacturers and the other foundations, to actually make them so that they are going to be more readily available in other countries, which is not a true answer there. So I think we're almost out of time. We've got a very good comment here from Trudy, who's a hemophilia patient organization in Zimbabwe. We continue to advocate for a time when our treatment is not entirely in the hands of donors. This conversation continues to give us hope. And I think, again, I think your message does is very inspiring, but you pull no punches in terms of saying it's a lot of work. So be prepared once you commit yourself to it, that it's going to be a lot of work. And as we all know, once that's done, the next step is also then taking up that designation, if we can, to actually make it so that it's actually going to be meaningful to patients. But thank you very much. This is the way it has to start. We appreciate very much your sharing your expertise and your willingness to continue to help us, and especially in the APAC as well. IPOPI is a huge force in terms of helping us with the rare disease framework, and the international rare disease organizations, have been such a major force, within their own disease groups. And the fact that, you're now contributing so much in terms of RDI, I think can only help us in so many ways in terms of being able to learn from the kind of experiences that you bring. So, we've used World Federation, Duchenne, Global. I think all of these alliances are essential to us in terms of being able to learn from each other. So thank you very much. Yes, thank you again. I think that takes us to the end of the actual session here. Is that right, Paloma? And that with this, we're going to transition into, we don't have another poll. Okay, we're going to transition into our COVID-19 global health crisis. I don't think we actually have a break, right? Are we kind of moving almost seamless into? Okay, I guess we could take like we could take a break. why don't we take a 2-minute break, and that way it gives people who are not staying for COVID an opportunity to gracefully exit if they're not staying, though we are really compelled by, I think, the importance of this discussion. In the COVID-19 discussions, we will have several presentations, as we said, from different national alliances or international alliances that have been working on surveying their members, understanding the impact and advocating on behalf of it. And then we're going to have some minutes for having an open Q&A in which we hopefully can not only share some experiences, but consider a way forward for us collectively. So thank you folks very much. Thanks to all of you who attended this global conference. This worked out so much better than we could have ever anticipated. And huge thanks to all the technicians behind the scene. I will say at the moment, before we sign off, because I know some people are leaving, that this is very sadly for me personally, but for many of us, the very last, I think, global meeting of the sort in which Paloma will actually be here with us as the director, and as she has so expertly done for us over the years from the very beginning of RDI, when we were still just a project under your orders, has been there at the helm, has helped us through so many transitions and stages, getting us through certainly that incorporation as a standalone entity. Paloma is moving on to take on some other challenges, and so we'll be saying at least officially goodbye to us as the director, but we're hoping very much that she will remain involved, because we know that the passion for rare diseases in RDI remains with you, as do our really, really warm thoughts and best wishes for you, Paloma. Thank you so much for all the years that you've given to us.
Thank you. Thank you all. Thanks. This is a great way of finishing this stage in my life.
Paloma's a person for few words, so I'm not going to press her to say much. I will say, and I don't know if Flaminia is still with us, the only good news out of any of this is that we have appointed a new executive director, Flaminia Makia, who has taken on the realms. Many of you who have been with the rare disease community for many years will recognize her as somebody with urologists for many years in a number of roles, but most recently there as the international development role, and has come back from 5 years working in the private industry, mostly around patient engagement. So we're really delighted that we're going to be able to have some overlap between Paloma and Flaminia, and hopefully have a very seamless transition as we look forward to the taking up all of these many challenges. So again, a huge welcome to Flaminia in terms of the RDI family. So thank you very much. With that, we will take a couple minutes and we'll come back directly into the COVID-19 discussion. Okay, we'll restart. This is actually, I think, somewhat informal. It was a last added on, but I think it would be extremely important. I'm going to just introduce, we're going to have 6 brief presentations, and we do mean brief, no more than about 5 minutes each, from 6 different national organizations, or in the case of yours, international. I'm going to introduce everybody, and we'll ask each of you to present in order, and then we'll have some time for an open Q&A. Okay, so Samuel, and I'm going to try your last name, Samuel Wioff, who's the founder, executive director of Rare Disease Ghana Initiative. We're so delighted that you're able to be here, and hoping that you're working well in your isolation there. Jan, it will be Sandra Courbier who's going to present on behalf of your orders the survey that they've done through Rare Barometer. Jesus Navarro, the Vice President of Alibert, will be presenting. Kelly Duplessis, the CEO from Rare Diseases South Africa. Lisa Sarfati is going to Director of Strategic Planning and Project Development from NORD, will be presenting on the survey they've done, and I will close it off with a brief presentation on a survey that we've done during CORD and our advocacy activities. So I'm going to hand it over to Samuel to start. You have to unmute there.
Good afternoon. You can hear me, but a great opportunity to join everyone today. Can you hear me?
Yes, we can hear you.
Okay, great. Yeah, so I'd like to share our COVID-19 strategies, what we did and what we are doing now. in fact, I must admit that COVID has really thrown majority of us to a different level. And so when Ghana recorded our first case, first 6 cases, we realized the need to inform our authorities about the need to prioritize or give some attention to rare diseases. And so we published our public statement, which can be found through our social media. Copies can be found through our social media networks, where we highlighted the need to focus on rare diseases, especially those with immunodeficiencies like PIDs. And so, okay. Yeah, so those with PIDs, we focus. We came out with a public statement just to inform our authorities the need to focus on rare diseases and have a priority in there. We also started receiving calls from the patients and some families about how COVID may impact their health. And so that led us to coming out with flyers that contain a lot of information on rare diseases that was shared among some families, that they could learn more about COVID and the strategies they could adopt to prevent the spread, as well as to also take care of themselves as they deal with COVID, as we all deal with COVID. So we printed out some flyers, and also we also needed, most of them also were reporting that they cannot go to the hospital to continue their care. And for most of them, and personally I witnessed the point where I called one of the doctors, and the doctors told me that some rare disease patients have been living with rare disease their whole life. This is COVID, and we need to prioritize take care of COVID. And so majority of the care was being stopped or halted due to COVID. So we needed to find a strategy to help with that. And so what we did, because our team is large and has some health professionals already on board, we formed a task force that could help to address some of these concerns. So, and that led us to launch a virtual clinic for 2 weeks, where they could access, during the lockdown period, patients could still access some medical consultancies for free. And so that we launched that virtual clinic. And some families were having challenges with accessing basic essential items during the lockdown period. Ghana, we went on a lockdown for 3 weeks. And so during the lockdown period, some of the families had challenges. And so we were able to organize some food items and some essential items that we gave to families who reached out to us with challenges with accessing essential food items, and that could also help to some extent. What COVID has led to is that we've seen that we didn't have emergency fund available to deal with emergency situations like this. And so because of that, we've launched a separate fund where we are fundraising for COVID. And so we are organizing series of fundraisers to raise funds into that emergency fund that will be used in any, from now and in the future, should there be any emergency situations that affect the nation or the world that we have to prepare for. And so we set up the fund. Our plan was to also launch an impact survey, but when we joined series of meetings and other webinars that were organized globally, we realized that there were a series of global surveys that were ongoing, like the Eurodis survey. So we paused on our survey. Also realized there were discussions within EDEC to organize a similar survey. So we pause on our national survey to rather share the international survey, rather to see what and then look at the data from the international perspective, what patients are saying from Ghana. And so we did not launch our national survey. We paused on that, rather shared the survey from Erodis and hoping that patients here in Ghana could also tell their story. And then it will be easier to compare the experience from Ghana to with other countries and see if there are any similarities or differences, looking at it from that point. So we did not launch our survey, and we are waiting for the outcome of the Erodis survey and other surveys to lead to a call to action based on what comes out. We as a national body, is going to call on our authorities and into an action. So that hasn't been done yet. We are waiting for the outcome of the survey that will lead to that call. In terms of the national fight for COVID, apart from launching our virtual clinic, which has given us a lesson where patients have learned to also consult virtually, though we had challenges, especially with internet connectivity and other few challenges. It has also demonstrated that we could achieve that. And so one of the goals moving forward is to maintain that virtual clinic, seek funding and sustain it to be used to manage, since currently there is not a national rare disease clinic run, we could offer that platform to major centers to continue to use to take care of rare disease patients, where we are actively involved in the care. And so we will maintain the virtual clinic. And then for the national fight, most of our healthcare professionals volunteered. We encourage them to volunteer. So majority of them, including myself, volunteered for the COVID response, national COVID response, where a majority of us volunteered our time. And so I'm a health frontline worker now for COVID. And then we also ordered for some ventilator splitters so that we could donate it to the treatment centers as our contribution to the national COVID fight. And so we've ordered the splitters, which will be in. Should be in anytime soon, so that we'll donate it towards the national fight. And we believe that that is going to contribute to a large. We don't want to hear stories where rare disease patients have been not been given care because there's no there are limited ventilators. We gave splitters to share the ventilators, and so in that way we'll be able to argue well for our patients. These are some of the few strategies that we put in place, and we are hoping that moving forward we'll be able to provide PPEs to the families who need them, and other relief items will be able to help them to access national relief items. Thank you.
Thank you very, very much. We just wanted to maybe interrupt a bit. I think it's worthwhile. We've had Rudiger Craig join us. We're so delighted. He has just come from the World Health Assembly, the closing meetings there, and we already heard him obviously from a tape message, but it's just such an honor that he chose to come over and join us directly. And he put in an offer that he says that he could brief us about the initiative with Public Health Institute and experts on COVID-19 and inequities, and he's suggesting that RDI could be included. So I wonder if we could just take a sideways movement and invite Rudy to address us. We would be so pleased to be on the cutting edge of this new information and really prepping ourselves up for this. Is that possible? Is it easy to get him in, Kulani? Is that easy to get Rudy on?
Yes, he just has to unmute himself.
Unmuted right now.
Oh, all you have to do is unmute. Okay.
We can hear you, Rivia.
You can hear me. That's nice. Thank you very much, and thank you, Dohan and Jan and Paloma, for being flexible in your program. Actually, I would have loved to stay on to hear the whole session, but I have another commitment coming up. So I just wanted to brief you on an initiative that has been launched by the World Federation of Public Health Associations, together with 113 public health associations and public health institutes as well. As public health experts are very concerned, as much as we are at WHO, that in the COVID-19 response, we will see a lot of inequities. And Samuel, thank you very much for your intervention just now, because that confirms very much what we also see. People with rare diseases definitely also belong to the group that might see less of attention when they seek care. And so I would like to bring to the attention of this initiative that actually looks at inequities all over, people, vulnerable people overall, people with chronic conditions, people who do not have health insurance and will have to pay out of pocket. All these people obviously are at high risk of seeing lesser care during COVID times. And I believe, and just wanted to check with you, that the issue of rare diseases needs to come to the fore in this group as well. The group had various discussions now also on Zoom and WebEx to organize themselves. The Director General has asked me to coordinate this group together with my colleague Naoko Yamamoto, and we will convene those meetings in due course. We are there. Also of notice that the United Nations Secretary General, Antonio Guterres, is also very much involved, and the Assistant Secretary General, Amina Mohammed, is also in that group. So we want to ensure that the United Nations response is well coordinated, that it is equitable, and that when and if a vaccine becomes available, that this will not be used for those who can just afford it, but that this becomes a common public health good, a global good for all, and then this could be deployed and administered according to the strategy, how the virus moves, rather than by, what shall I say, nationalistic ideas. So I just wanted to brief you on that, and if you allow, then I would like to include the issue, and then we can see who from RDI could perhaps join the group. Thank you very much, and over back to you, Darren.
Sorry, I think I'm still. Thank you so very much, Rudy. That was tremendous information to receive, and the fact that you thought of us, and I think consider us in terms of being, valuable partners in this. Obviously, we would be so keen to take it up, and as you can see, unfortunately, we know that you cannot stay for all the presentations, but I think you will hear echoed what Samuel so eloquently put forth, and that is in every single environment that we're talking about, regardless of how the countries are actually, in economically situated or health system situated to respond to COVID-19, that rare diseases are indeed being pushed aside in so many ways. And we are certainly not trying to say that we need to be ahead of anybody, but we definitely feel that it is essential that rare diseases continue to be part of the solution. We've certainly brought forth the statements from WHO and the UN that also supported them. And I think what you have said personally as well, that UHC needs to be considered, UHC needs to move forward even as we're responding to emergencies and other kinds of epidemics. So we are so very grateful to you for the offer and for the information, and we will definitely look forward to working with you. Kudos to what you and all the people there are doing at the WHO, and certainly, you know, for your personal support and attention to us.
Very, very welcome. Thank you very much. Yeah.
Okay, so that's a huge opening, and I didn't quite properly thank Samuel for his wonderful presentation. I was very keen to make sure that we got Rudy while he was here. We may not have all the time that we want, or we may be running over. I think it depends on what the audience is willing to tolerate. I do want to go back to and invite Sandra Courbier to present. Rare Barometer has been doing an amazing survey on COVID-19 and rare diseases. I know many of our people in Canada, we've been urging to respond to it as well. So I'm going to turn it over to you, Sandra.
Yes, can you see my screen?
Yes, indeed.
Okay, so we wanted to say a few words about the survey that we have launched in the...
Can you put it into presentation mode? I think we're seeing all the notes as opposed to just the presentation. Yeah, it's better. Well, not quite perfect yet.
Okay. Oh, yes, it's in a weird mode. So I'm just going to... Okay, I don't know why it doesn't work. I think I'm going to stay like this.
It's okay, we can see it.
Yeah.
Yeah,
so
it's good enough. Yes.
Yeah, so just a few words about our response to the COVID-19 pandemic. So we have launched a survey in the middle of the pandemic in order to collect information on how the COVID-19 pandemic is affecting rare disease patient care, social care, employment situation, and also mental health. And the idea was to be able to identify in the middle of the crisis, to identify red signals and to be able to advocate for immediate needs for rare disease patients. And we have started to communicate about the results, about the most striking result, to highlight rare disease patient specific situation in the middle of the crisis. And we will also carry out more detailed analysis of the survey in order to draw recommendation to prepare for future crises and to prepare policy messages to advocate for the right of people with rare disease in the middle of the deconfinement period. So this survey was carried out through the Rare Barometer program, which is the EURORDIS evidence-based advocacy tool that uses social science methods to transform rare disease patient experiences and opinion into figures and facts that we share then with decision makers. So it was an online quantitative survey, and 8,300 respondents have taken the survey so far. So the survey is now closed in Europe, but is still open if you want to participate until end of May for countries outside Europe. It is translated in 23 languages, and as I said, the goal is to voice the specific needs of rare disease patients and to propose practical solutions to ensure that rare disease patients are taken into account when handling the pandemic. So the survey was disseminated worldwide, and so I'm going to try to zoom a little bit. So as you can see, we have a very good representation of respondents in Europe because it was obviously a EURORDIS initiative, but also we have quite a good participation rate in other countries outside Europe. I'm thinking in particular about South Africa, about Australia, New Zealand, also in Brazil, Chile, in the US as well. Some participants in Ghana also, I see. And I know also that many of you have done a very significant effort in disseminating the survey, and that sometimes it was difficult. I heard that, for example, in Venezuela, you had some internet cuts and weren't able to disseminate the survey as a result. But thank you very much to all for your dissemination efforts, and you still have 2 weeks to be able to disseminate the survey and then to have results for your country. So this is the repartition of the respondents in Europe, so that you can see maybe a bit more in detail. So in some countries we have reached a very high level of participation. In France, for example, with almost 1,100 participants so far. And as I said, we have started to talk about the result and disseminate some of the preliminary findings of the survey that include the fact that 9 in 10 rare disease patients have experienced interruption of the care they receive for their rare disease since the COVID-19 pandemic started. And this was definitely one of the most striking results that was highlighted through the survey. And what concerns the very important amount of patients is the number of patients that have seen their appointments for rehabilitation therapies, such as ergotherapy, speech, physical therapy cancelled or postponed. 8 in 10 have seen these appointments cancelled. So just wanted to specify that these are results, international results, so without breakdowns. And after that, we will be able to break down the results by country. As you can see, also close to 7 in 10 have seen their appointments with a general practitioner or specialist who provide care for the rare disease cancelled or postponed as well. Same for, so more than 6 in 10 for diagnosis tests that are sometimes very important for the continuity of care for rare disease patients. Also, medical therapies at home or at the hospital are very much affected. Those who need these therapies are almost 6 in 10 to have seen their appointments cancelled or postponed. Almost 6 in 10 for psychiatry follow-up, and more than half of those who had appointment for surgery or transplant have seen this intervention cancelled or postponed. So obviously this is overall general results, and there are variation according to countries. And as I said, we will be soon able to provide more detailed results and sort the data by country, but also by disease, by group of disease, gender, and to be able to draw a recommendation from the survey, and also provide to each patient organization, national alliances who have participating in the dissemination effort and who wanted to use the results of the survey. We will provide the results for use for your advocacy work.
That's it?
Yes.
Thank you very much. Okay. Brilliant. Okay, so we'll move. Next is Jesus. Jesus, do you want to talk to us on behalf of Ali Bear?
Thank you very much. Paloma, do you can give me support for showing the slides, please? It's basically, it's very shortly. We have 5 minutes in according to time, but we can show you how we try to face that situation of the COVID-19. In our region, we have a lot of problems for supported the rare barometer voices, because in many parts of the countries, they don't have any opportunity to answer the survey because they don't have internet access. that is one of the points of we want to show in faces the COVID the COVID problematic in Latin America. With this survey, we developed a positioning across America Latin for a statement for showing of our authorities in health, but we don't think that is enough because we have many problems in economic issues, because we health systems is in facing this problem with the money, they taking all the money for in face the problematic in there. And for example, in Brazil, they are taking money for COVID, for attend COVID, and 18% of the patients with rare diseases, they don't have treatment for rare diseases. Is very sad. That notice for us, but it's our reality. In addition, we developed a video where we push together with other entities different projects now especially focus on facing COVID, where we show very different aspects to attend the people with rare diseases, because they are a special attention people for the comorbidity associated with the rare diseases. We developed a video. We want to show you, Paloma, if you is possible, show this video where we express this video in our platforms. And
would you like to show the video now?
Yes, please.
Okay, I'll stop sharing.
Mi hija tiene síndrome de Jacobsen.
Mi hija tiene disfunción hipofisaria.
Soy la mamá de Celia. Represento a la Asociación Internacional de Familiares y Afectados por Lipodistrofia Infrecuente, AELI.
Represento a la Alianza Iberoamericana de Enfermedades Raras, Huérfanas o Poco Frecuentes, ALIBER.
Represento a las familias con enfermedad de Wilson.
La Asociación de Raquitismos y Osteomalacia heredados desde Perú.
Represento a la Asociación Española de Raquitismos heredados.
Represento a la FEPER.
Tengo síndrome de Marfan.
Vivo con acromegalia.
Con varias enfermedades raras.
Tengo una enfermedad crónica. Mi sistema inmune está comprometido.
Soy paciente y representante de la Asociación de Pacientes con Angioedema Hereditario del Perú.
Soy paciente de diabetes insípida.
Soy paciente con PIB.
Soy paciente de hipertensión arterial pulmonar idiopática.
Soy paciente con enfermedades raras.
Soy paciente con enfermedad de Fabry.
Mi hijo tiene la enfermedad de citrullinemia.
Mi hijo Pablo tiene una enfermedad rara sin diagnóstico.
Seamos
responsables.
Paremos el contagio.
Paremos el contagio.
Cuidarte.
Cuidarte
es cuidarnos.
Es cuidarnos.
Es cuidarnos.
Cuidarte es cuidarnos.
Yo me quedo en casa.
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 With these two initiatives, we try to show the people how they care about the COVID. But how I say this, I think is not enough, because in our region, the people try to back to the normality for economic reasons and not for healthy reasons. That is very sadness, but this is our reality in Latin America. It's not comparable. It's very difficult to try to have a parameter from Europe or United States or Canada too. But with these initiatives, we try to invite the people to take care about and try to face the COVID and showing that to the health authorities too in many languages, because we have the language barrier with Brazil, the Portuguese. We have a really deep problems there for the access to the internet to try to show what take care. That's all.
Thank you so very, very much, Jesus, for all of that, and certainly for all the work that Ali Bear is doing, certainly for bringing the rare disease community to the forefront for the important messages. I think, as Samuel indicated as well, the impact in many countries is, quite devastating when you think about it in terms of the health resources already. So huge congratulations to Ali Bear for this initiative. Okay, I'm sorry to keep rushing on, but I think we have to do so. Kelly, can you present for us?
Yep. Hi, so sorry. I had all intentions of getting slides ready, but that hasn't actually materialized. So here I am. So we obviously are heading into our 8th week of COVID disruption, and the impact on the rare disease community has been catastrophic. Rare disease patients are obviously at the highest risk, and even though the national lockdown has been aimed to lower the curve of infections, our patients still remain the most vulnerable of those affected. So we did participate in the Rare Barometers survey, which I think just highlighted what we already knew. And I think that the biggest concern, there's been two major concerns. The first one is the disruption or complete deferment of treatments and access to any form of therapeutic or supportive care. We have approximately 50% of our patients stating that they've had some form of disruption to their treatment, which is obviously a major concern. And I think more specifically is that those who have had their treatments postponed indefinitely, they haven't been given any sort of indication as to when they can expect to have their treatments re-implemented, which is obviously a major concern and a huge factor of anxiety. So there has been a bit of stuff around that. The second issue has been what was highlighted by the WHO, and that's been the loss of medical insurance. So many of our patients have not been able to pay for their medical aid premiums due to the economic downturn. South Africa, I'm sure you know, everyone's raving about our fantastic response to COVID and that we've done so well, but essentially our country was put into lockdown before we could even spell COVID. And so there really wasn't much time for us to prepare from a economic perspective, as well as an alternative preparation in terms of what was necessary for us to ensure that our patients could still get their treatments. So as a result of that, we've been relatively on the back foot, and from an economic perspective, many of our patients have lost their cover. So we're sitting in a position where we've got about 48% of our patients who are now going to be deferred back to the state system, the public health system, which is already under massive strain. So that is obviously quite a dramatic issue. So yeah, and even in these times, we still remain the only organization serving the rare disease community in South Africa. So our needs as an organization have become even more urgent with this pandemic. So aside from the immediate patient problems, how have we as an organization been impacted? Obviously, the economic downturn has given us limited opportunity for conventional fundraising. Things such as sports events, gala dinners, event-based fundraising has essentially come to a standstill because of our prohibition on being able to gather. Our small and medium-sized businesses are not functioning at the moment. I mean, we are now going into our 8th week of economic shutdown, which is catastrophic for an economy such as ours. And we've had a lot of funding that has been diverted, and the bigger foundations and organizations have all donated into our solidarity fund. So that's placing us at massive risk. Even as an organization, we're not able to rally the necessary support to provide the patients with the real needs that they have at the moment. We've had issues with regards to stock shortages as well. South Africa, particularly the rare disease sector, is heavily reliant on cold chain storage of medications. And because I don't know if anyone, you guys are still looking like you have lots of flights coming over if you look on Flight Tracker or Flight Radar, but I mean, the African continent has like 3 airplanes flying over us at any given time, and that's literally the limit. So unfortunately, we've actually battled to get a lot of these medications in because they're reliant on the commercial travel to get them in. So that's also become a bit of an issue. So what have we done as an organization? The first thing was we have collaborated with a large variety of community groups together. And as a result of all of that, we have managed to develop a website where patients or any member of the community can actually list their responses, and then we are able to respond in the form of food, in the form of sending out medical assistance, getting them to a hospital, etc. So that's been pretty good. And actually it's identifying the opportunity that's come of this, and that is the rallying together, I suppose, of all NPOs across the sector, which has been good. We have developed a stock out notification process on our website, and that essentially allows patients, we're not relying on industry particularly, or even healthcare professionals to notify us of stock shortages. We've shifted the burden of that to the patient, so that they are, as soon as they've been notified by their pharmacy that they cannot get their medication, they have the ability to notify it with us, and we then take it up with the relevant distribution channel, simply because normally in South Africa you have to rely on the distributing company to report that stock shortage, but it simply just wasn't working because everybody's so under-resourced at the moment. And that has been quite helpful in improving the turnaround times. We have also engaged with our medical aid regulator in terms of what can be done to assist the patients that are at risk of losing their medical aid cover. The dedicated COVID relief fund that we have started has been specifically put aside to try to help patients with their immediate needs, and making sure that we can still provide them with access to alternative therapies, etc., where possible. We did also add a website portal specifically to COVID on our website, which is providing patients with direct communications that we have now gathered from around the world with regards to their specific diseases, which is one of the massive challenges. And that subsequently is being fed through to our National Department of Health, which has been quite helpful in helping medical professionals, etc., determine who's high risk and who isn't, and what information there is with regards to patients of that particular disease entity, obviously being impacted by COVID. We've obviously done quite a lot on education as well, trying to get patients to understand social distancing is not something that's new, I think, to any rare disease patient. We've lived a life of fair isolation to some extent, so I think we've been able to lead by example. And in some ways, I think it's actually assisted in reducing the stigma that we've experienced, where patients have, generally speaking, had to isolate themselves previously. I think the rest of the country is now having an understanding as to the importance and the necessity of that. So there has been some positives there. We have rallied to provide emotional support where necessary. We have counselors that are available to our patients completely free of charge to assist them with their emotional and anxiety and depression. We have had a massive spike in depression, gender-based violence, as well as suicide in South Africa as a result of the economic downturn. So we've made whatever we can make possible to assist patients with that. And then I think most importantly has just been us really rallying, and we have taken the lead. We've written open letters to our president. We've featured in various news articles and media engagements, etc., really just imploring our government to ensure that the NPO sector stays alive during this time, and that you know, government keeps saying to us, we're going to need our healthcare partners more than ever to assist patients who are not impacted by COVID, you know, to assist it's not like all the chronic patients simply disappeared overnight. And government's been telling us that they're going to need us more than ever to assist those patients in maintaining their treatment and compliance, etc. But the reality is that 3 months from now, there'll be very few of us organizations left if we don't get urgent fiscal support and some form of stimulus in play from an economic perspective. So although it is very bleak, there has been opportunities. We have tried to engage as much as possible with those opportunities.
I'm going to have to interrupt you. I'm going to have to interrupt you. I think we're so totally out of time. You know, we're even beyond what the end of the session was. So, and maybe if you can just wrap it up, I really do have to we have to make a decision on how we want to close off the session.
That was really my last point, just to say that we had done what we can, specifically to try harness on those opportunities and not necessarily see it completely in a bad light.
Okay, thank you so very much, and for such a not only a detailed response, but all the initiatives that you folks are engaged in. I need to do a little bit of a housekeeping check here. What do we want to do? Because we originally were going to be done at whatever 45 minutes was in terms of everybody's individual time zones, and we're now already beyond that. How do we want to conclude here? We still have, you know, about 70, 80 people online. Should we go for the rest of the hour? Should we try to do that? And maybe we can ask.
I know Lisa's presentation is very short.
Okay, so can we do that? We'll do it quickly. And it sounds like we really are going to have an opportunity maybe to come back together, take up the opportunity that Rudy's put in front of us and really talk about what that could be. I mean, that provides a huge opportunity. And maybe we could have a working group that might be interested and really focuses on this from across different environments. So Lisa, I'll turn it over to you.
Okay, can everyone hear me?
Yep.
Perfect. Okay, let me just share my screen. As Paloma said, I will be very quick. Okay, so similar to some of the other speakers on the panel, NORD launched a survey. We launched it in early April. And the purpose of the survey was to understand the extent of the issues and concerns that patients in the US and their families were experiencing. So through the survey, we had 772 responses. Not surprising, 98% of those who responded were worried about COVID-19, 74% had a medical appointment canceled, and only 60% of those were offered a telemedicine or telehealth appointment as an alternative. 95% were impacted by the virus and the pandemic. 69% were concerned about medication and medical supply shortages. 29% lost their jobs, and 11% of those who lost their jobs also resulted in the loss of their health insurance. So there are very serious issues that we are dealing with in the US, like some of the other countries who have already presented today. Some of the most common concerns that we're seeing are patients and families not being able to access personal protective equipment, such as masks and gloves, things that they already needed prior to the pandemic, and now they're even harder to get access to. So the inability in the US to get access to appropriate testing and the high risk of false negatives for those who do get tested. As mentioned, drug shortages, including those who are participating in clinical trials. Access to medical services is a big issue in the US. So things like home infusions, getting routine lab work done, and access to therapies such as social therapies. Financial stability, as I mentioned, so because of the loss of income, we have a lot of people who are unable to afford their medications as well as their general living costs. So things like their mortgages, their rents, their utilities. Patients here are very concerned with equity of care if they have to find themselves in an emergency room setting. So things like discrimination during the triaging process, if they have a chronic condition and whether they will receive a ventilator or not. And they're also very concerned with having to return to work if they or a family member are immunocompromised or at high risk. And we have a lot of people who are just asking about how they can stay safe, not just now, but when this is over. And we don't know what that looks like. So NORD took all this data and the responses that we received, and we published a report on our website that's available for download if you want to learn more about the current state of affairs for patients with rare diseases. We are using that data to inform our response to the pandemic, from an advocacy perspective, our educational resources, also by providing financial assistance programs. As states in the US start opening back up and relaxing their social distancing requirements, we know that rare disease patients and their families are going to be put at higher risk again, which also puts them in a very difficult position about whether or not they can and should return to work if it's required. So like I said, we're going to continue to monitor their experiences. We'll be launching a follow-up survey in early June. It will drill into more specific topics such as telehealth and clinical trials so that we can really understand whether there's something that NORD can do to support the community with those difficult issues. And we'll also be comparing the data from the first report to see whether or not the experience has changed on a state level, on a national level, as well as looking at it from a very disease-specific perspective. And so I just wanted to share some of the resources that we have created so far. So our policy team is working very hard at a state level and a national level to address some of the issues with access to medical treatments. So things like home infusion services, telemedicine, and prescription refills. They're also working by reaching out to governors across the states to ensure that discrimination in the COVID triaging process and in emergency room protocols doesn't occur, and addressing issues such as paid leave. And again, this is not an exhaustive list, but just representative of some of the things that we're doing. We also launched 3 programs to support families who are struggling financially. So providing assistance for non-medical items such as mortgages, rents, utilities, but also helping to cover premium and co-pays through our medical relief program. And unfortunately, that is only to patients in the US. But for those of you who do have individuals who are struggling, please let them know the program exists and they can apply on our website. And we're also doing a lot of work to respond by providing educational resources. We're doing a number of webinars and on-demand videos that we're publishing on our website. So we have a rare disease expert series where we're talking with physicians either about specific disease categories or on just general questions that we're getting from the community. We are publishing resources on how to maintain your physical and mental health because we know how important that is right now. We have webinars on how to understand the current status of testing, treatments, and vaccines, drug supply shortages, telehealth. We also are working to support patient organizations because we know that they're also being severely impacted by this. So helping them to understand how they can activate their medical boards, how to utilize virtual health platforms, fundraising during COVID. And we're also looking at the intersection between using telehealth to support clinical trials that are ongoing so research doesn't get completely stalled. So I'll stop there. For more information, I've put the link below where you can find some additional resources from NORD, and hope this was helpful.
Thanks. Thank you so much, Lisa. And I've got a very, very just quick number of slides, which I won't even go into in deep detail. But if you don't mind, I just want to highlight to build on what everybody else is saying in terms of what's happening here in Canada. Again, you know, we've got a very, very good public health system, I think, as most people know. And in fact, to some degree, I think we've been able to respond amazingly well to COVID-19 because of the strength of our public health system. On the other hand, we're one of those that, even though we've got very good health care for most common conditions, the care for rare diseases tends to really lag behind. So we also did, I'll just speak to it now. Can you get it up? I think all we're seeing is the, we're not really seeing the slides. I mean, I think you have them. Just to say, I'll just speak while we're doing it. Oh, there we go. Yeah, just applying the lessons. I won't go into deep detail because a lot of it you've already heard. We sent out a survey, and actually in less than a week, we had about 300 responses. So we really wanted to capture some quick responses in order to be able to try to act on it. The same as Lisa said, I'm not going to go into the details into this impact. Everything that you've heard from others is exactly what our patient community was saying. I will say I was truly surprised. I'm not sure why I was surprised, but I was truly surprised at the level of impact in terms of the inability to access, the impact in terms of trying to get not only just treatment, but also just getting into the hospitals, the access to health, to other kinds of health services. Some of the people said to us, quite frankly, we have great telehealth, but you can only get to a GP through your telehealth or your family physician who knew nothing about my rare disease. So it spoke to us again very strongly. Go to the next slide because I don't think I think this is, We did send also a survey out to our pharmaceutical companies because we were concerned whether there would be an impact in drug supplies to patients. And to a person, or at least all the respondents indicate to us there were no impacts in terms of actually continued supply of drugs. And we saw that many of the companies were also going to greater lengths to provide alternative infusion sites, to being able to get people access to testing if they needed to before they could get their treatments. We were quite, I think, pleased with the kind of step up that our companies were doing in order to make sure that they were serving their patients during this period of time. We also were very fortunate, I think, compared to many others, that the ongoing clinical trials they reported were not interrupted. There were some delays in starts and new enrollments, but in terms of access to clinical trials, I mean, especially for patients, obviously in these kinds of very critical trials where you needed to have continual access, again, companies were really stepping up for us. So we were very pleased with that. The next slide. As a result of our being able to do this survey, though, one of the, back up one, one of the important things we did have out of it, we published our results. We actually held a webinar on it, I think the same as Nord. We also wrote letters to all of our health ministers because, again, health services are provided on a province by province level, but also to the federal health minister. I think because we were so early and we were visible, the Parliament hosted hearings on COVID and the responses and the impact. And we were one of the 4 patient organizations that got invited to actually present, which we thought were pretty amazing because the others were cancer, cardiovascular diseases, and the Lung Association. So to be there, I think, was a huge opportunity to make sure that rare diseases was going to be included. And for us also to be able to make the step up to say, this is why we need centers of excellence and why these centers of excellence need to be networked. And can we move forward in terms of doing that? So a whole lot of, you know, kind of what Jan and Matthew was talking about, we need to have those. The second thing is that we want to make sure that we recognize, you know, rare diseases as this distinct specialty. So we need a plan that will be around just the rare diseases, the same as we have around others. We've got a plan, but it's never been formally endorsed, even though bits and pieces as they go forward. And we also had, I think, quite interesting, that's already put out early on, is that we can support you in putting together a parallel program for how we can deal with ongoing needs for chronic diseases, but especially rare disease patients. So as we're moving forward in this next stage of planning, let us be at the table. We need to help put that plan together. Even as we're triaging for surgeries, we're seeing that rare diseases are not getting the same kind of attention as cancers, cardiovascular disease, etc. So we need to be part of that planning. And we also echoed it with the last statement, and that is we understand, you know, we really do support the importance of having an innovative pharmaceutical industry in our country. And we need to make sure that there are, in fact, collaborative relationships between pharma and the governments and the funders, that this is not a war. We cannot be, you know, being at odds with each other, because we absolutely need each other. And that was it. We're very hopeful that we will be continued into these programs. It is right at noon, so I'm going to kind of close it off, I think. Unfortunately, we didn't get a whole lot of chance for discussion, but I'm just delighted that we had some great feedback from, you know, Africa, in Ghana, where you can really see, you know, the huge impact in terms of COVID on a very, very, you know, challenged system. I can't thank Jesus enough for trying to bring us some real perspectives around Latin America, where diverse economies are really, really, you know, having an impact, and how Ali Bear, you know, is trying to work across those countries to provide a, you know, a unified voice, et cetera, for rare diseases. I apologize to Sandra and Rare Barometers that we were not more visible in your survey. I think the problem is that we'd already just done our survey right before we sent out the links to yours. So I'm not sure that, I think some people are getting survey fatigue in all of this, but it has been certainly tremendously important for us to actually be part of that international space. So we may try to push it one more time, knowing that the survey is still open, see if we can increase the number of Canadian responses to it. I'm going to close it, and unless there's something else that somebody else wants to make as a really important closing comment here. Oh, I get it. Kelly says, can we have questions? My problem is that we are out of time, and I myself have to go into another webinar, which is waiting for me right now. So I cannot stay on this, quite frankly. So I don't know what we can do. I think we
need to do a follow-up.
Okay. Yeah, either a follow-up, a next follow-up, or Paloma, if yourself you can stay for 20 minutes more with the
I can.
For the people who can stay online, maybe with you and Clara, then the conversation can go on between the ones who can.
Yeah, and we'll take notes.
Okay.
Okay.
We'll
I
take notes, but I
apologize.
think
Yeah.
this was obviously the beginning of something.
Yeah, but that was great. I mean, it was great to have that first opportunity really to exchange. It shows that that was really needed. Thank you, Paloma. Yeah, and thank you, Joanne.
Okay. Thank you very, very much. Appreciate it.
So, Paloma, I let you.
Yes, absolutely. So whoever, I'm going to read out the questions that we've been receiving. Most of them are comments, but we've had some questions regarding the Reverometer Voices survey. Obviously, Jesus was reminding everyone that in many countries in Latin America, it has been difficult to respond because of technical issues, no internet in Venezuela. I mean, we understand that, you know, some countries are in a desperate situation. You know, Sandra, you know, is reminding us that there was a deadline. I'm sure there will be another survey of this kind coming up soon, and we'll have more participation from more countries and those that could not participate on time.
Yeah, until the end of May, outside of Europe, until the end of May, everyone can answer to the Reverometer survey if they are interested.
So you still have time until the end of May?
Until the end of May for countries outside Europe. For Europe, it's closed since last Sunday, but for outside Europe, in every countries, it's still open. So particularly, I think for Latin America, it's useful because there is already a significant number of answers. So if there are more, then there can be some consolidated analysis. Yeah.
Yeah. There's also a comment from Maureen Smith from Cord, Canada, which I thought was very relevant. She says, another significant impact is that this rapidly evolving, unprecedented crisis, patient groups, patients, and caregivers are often not at the COVID-19 decision-making table and as partners in research. So they're not part of defining priorities, studies, etc. So that's important, and even in very developed countries like Canada.
Paloma, sorry,
yes,
if I can,
go ahead.
I don't know if anybody else has experienced this, but I have, and I'm considering getting a legal opinion. It would obviously only apply to South Africa, but I'd be interested if the same concept has been faced by any other country. So in South Africa, we've obviously, as I stated, have had a large amount of patients who have simply had their treatments stopped or deferred and indefinitely. And my question is, on the ethical imperative of taking an existing patient and setting their right to access appropriate health and putting it aside to the benefit of a possible patient or a possible contamination, which is not yet guaranteed. And I question the ethical impact of that. Particularly, you know, we've had other issues where our hospital protocol. So we've got patients who go for infusions on a weekly or every second week, you know, enzyme replacement, etc. And those patients have now been told that they cannot access the hospital without having a test to prove that they are negative for COVID, but they need to have this test every week, which is completely invasive for a child, every week and at their own personal expense. So again, you've got a financial implication for a possible infection over the existing rights of a patient. I'm not sure if any other countries have experienced this, but I don't know if anyone's got any advice for me, maybe also in terms of interpretation of the World Health Organization. Obviously it's a complex issue.
It is a complex issue. I'm trying to see if someone has responded, but that hasn't been addressed in the surveys that we've been looking at. But maybe Sandra, you can get ideas of, you know, what should be included in the next surveys, because this is a very interesting, important aspect, the ethical aspect of testing and how frequently, and especially children. So it's good that you voiced it, Kelly. Thanks for sharing that experience. It is a very valid point. So I think the best we can do, because we don't have that many people left on the call, is to take note of all that and refer it to the right people. I think these are, Kelly, things that we should definitely take into account in the design of the surveys that I'm sure will be coming out after this. I mean, this is not the first one. This is not the only one. It's only the first one. And as the crisis evolves, but please keep on feeding us with your experience and what you see on the ground, because we obviously need that. We need that kind of information in order to tailor the surveys and to also not only the surveys but the statements. One of the reasons why we put this panel together at the last minute, really, we recently decided to do that, is because we were trying to gauge the interest and the need for a common position. Now, obviously, this common position of RDI will not be able to go into any kind of detail about, you know, the particular situation in each part of the world and in each country, but at least, and I think it's come up clearly, not only from from what you've said, but from what other people have said, and from information that we've been getting in the last, 8 weeks, that there's a need for that, for a common statement and a common position on all that, because we see over and over again the same problems being experienced and the same sense of urgency. So rest assured that will be the next step. And we can only make those statements effective if they're fed with information from the field, from what you're facing day after day. So sorry, Kelly, we cannot provide you with legal advice right now, but these are all important things to say.
I think it was, for me, it's just important to understand. I just wanted clarity on whether it's just us that's having this particular problem, or if there are other countries where this deferment, this just instantaneous, sorry, you no longer count, we'll let you know when you're important enough again, has come up. It seems nonsensical that we've spent so many millions of rands investing in these patients and getting them compliant and getting them onto treatment, to let it all go now on the premise of an alternative threat. There will always be alternative threats, and the cost of restabilizing these patients after not being treated for months on end is obviously a massive concern.
Yes, no, you've raised very, very, very important points that I'm sure will be echoed by other countries which are in similar situations. Maybe South Africa is also particular, but I think many of the concerns are the same. You also raised a point that I had never thought about, which, if I understood correctly, you're saying the lockdown was almost too fast in your case. You were praising governments for taking action. I'm from Peru, actually, and in Peru, a very underdeveloped country, they locked immediately. There's absolutely no flights from any country going into Peru for the last 6 weeks, and we praise our government for having taken such effective and rapid action. But I had not thought actually of the side effect, which is, of course, that doesn't leave any room for maneuver and for preparation, especially when you're dealing with treatments that are complicated to administer and to procure. So that's definitely a very interesting point that we should take into account when we make this statement. I mean, I'm honestly calling for all of you to use RDI as a platform to do that, to do exactly that. I think we're gonna have to call it a day now. Jan apologizes he had to leave. I'm just trying to see if there's someone else who has a particular comment or question. We see in Germany, I didn't dare, as your problems in South Africa are so much bigger than, but in Germany, especially children are lost in the COVID-19 system because everything has been prepared for the COVID-19 patients and many important treatments for children have been canceled. So yeah, absolutely, not to forget the others, the ones that are not affected directly by the disease and that are left out of the system. So we obviously need to keep all that in mind. I think I'm going to have to close this meeting. It's been incredibly successful in the sense that I think we've proven that there's interest, and there's more than interest, there's need for this kind of platform. There's absolutely need for this kind of platform. I think we're filling a vacuum. There is really nothing else of this kind. I'm sorry if sometimes it's not organized to the level that you expect, but we're really trying our best with the resources that we have. And the only thing I can tell you is that I'm sure that after this COVID session, it's become clear that as a community, the patient community, the rare disease patient international community has to come together and generate some kind of position. So I'll leave you with that. Stay tuned and keep on feeding your experience through us and sharing with the others. Use also the Facebook workplace of RDI that we have to ask those questions like the one Kelly had. You can make general comments, but you can also ask specific questions to the other members of the community. And I know that if someone has the answer, they will definitely be happy to respond. With that, I think I'm going to have to say bye to everyone. Stay safe and keep well. Bye-bye.
Bye.